Good morning. Welcome, everybody. We're in for another day of great topics and great speakers. Make sure you sign in if you want CEUs on the registration table. And then also prepare your roast and toast for Jay tonight. We're going to celebrate his birthday right after the conference. And then don't forget, if you haven't picked up your Eclipse glasses, make sure that you get those off the table and be here at 9 o'clock in the morning for that. We're going to try to stay on time. So, yes, ma'am. And then goat. Caps. All caps. Yes,
the kayak at noon. We have
Oh, yeah.
Nine registered.
Okay.
All the, and 12:30 to 2.
Okay.
They have a 1 hour
That's right.
outing.
Okay. Another invitation from Jay as a gift to you. 12:30 to 2, there will be 9 kayaks available. So if you want to kayak through the marsh, they're going to be right down on this dock. Is that correct?
We'll have to go around over to the kayak.
Oh, we'll go over to the kayak facility, walk around. So anybody who wants to kayak, join us. Thanks, Jay. Okay. And we've already had an introduction of Dirk, but this morning he's going to be talking about Thalamocortical Dysrhythmia, something I'm still trying to understand and see. So thank you so much. Should I whistle?
Yeah. Good morning, everybody. So I will talk this morning about Thalamocortical Dysrhythmia, and it will be an extension of what I've been talking about yesterday on acute and chronic pain. The basis of this goes back also to the Bayesian concept of brain functioning, where our brain basically perceives by predicting what it expects to perceive and then updating that with evidence. Now, so from a practical point of view, our brain creates a model of the world and also a model of the self, which is adjusting, allowing us to interact with the external world. So based on that, it creates a prior belief, which statisticians don't like, because it builds in some kind of subjective aspect into the statistics, and then that will predict what we are likely to encounter, and then it will look for support for that prediction, and the prediction can be right or wrong, which will then lead to the posterior belief, which is ultimately what we perceive, what we think, what we feel, etc. Now, thalamocortical dysrhythmia, as it was discovered by Rodolfo Llinás, is when there is a deprivation of evidence, so that the prior belief cannot be updated to what's really out there in the world. And so then the perception or the posterior belief becomes more likely like the prior belief without updating because of a lack of evidence, which could be because of hearing loss, visual loss, which could be of any sensory, but also of any emotional, any cognitive, any autonomic deprivation. So the basic concept of thalamocortical dysrhythmia is that if you have sensory, emotional, cognitive, or autonomic deprivation, so a lack of input, that your brain will respond in a standardized way. And one of the aspects is that if you don't have any support, you're more likely to get prediction errors because what your brain predicts can't be verified. And these prediction errors come in general at the sensory prediction in gamma. And then, of course, if there is a prediction error, it means you were wrong. And then if the brain decides the prediction error is important enough or salient, then that has to be distributed through the brain for conscious processing. But as I mentioned yesterday, the salience of it depends on the context. It depends on, for example, stress, as well as on the hierarchy of needs. If there is something else that is more important to be prioritized for processing, that will be processed, and then even if it's salient, might not reach the level of consciousness. But ultimately, if the brain doesn't have the information that it needs to make a decision on what to do next, it will just fill it in with what's stored in memory. And this is done in theta, usually in theta frequencies. And if the brain deems this is important, then it will also suppress the suppression of the so-called input, and that will then lead to constant filling in related to the gamma. And as you know, gamma is just normally it waxes and wanes. If you do a recording and you can see it constantly, it usually pathological. And remember from yesterday, if you have auditory input, it only becomes you only become consciously aware of it if it connects to what you can call consciousness enabling networks, which are our triple network. The default mode, because it has to be related to the self, the central executive network, as well as the salience network. And the salience network just pushes stimuli that might not be perceived otherwise to the level of consciousness. So,
could you define terms, Dirk, please? How are you defining gamma?
so gamma in all our studies is any frequency above 30 hertz. But we tend to record only up to 45 hertz. So we don't look at high gamma because it becomes a little bit difficult with simple EEG to make sure it is gamma and it's not noise. So the gamma in our studies is between 30 and 45 hertz. Now, if you have a little bit of deprivation of input, just a little bit of hearing loss, then you can find the missing information in the adjacent areas in the auditory cortex, somatosensory cortex. But if there is a big gap of sensory input and you can't find the missing information in the adjacent sensory cortex, then you have to resort to parahippocampal or hippocampal memory. So there is two kinds of filling in of the missing input, but both tend to relate to what we call thalamocortical dysrhythmia. Now, pain or a painful stimulus only becomes, we only become consciously aware of it if the pain is salient. And from a practical point of view, if the input of a painful stimulus is suppressed by pain inhibition, you won't feel pain. So normally, as we've been sitting here for a whole day, that should lead to pain, except if we suppress the painful input. So as long as these two pain-provoking networks are counterbalanced by a descending pathway, you should not feel pain. And this can be computed in a very, very simple way. So if you compute the current density in the somatosensory cortex and the dorsal anterior cingulate cortex using a simple Loretta region of interest, and you divide it by the pre-general inhibitory current density times 2, if that is 1, then there's no pain. If it's above 1, meaning that there is more current density in the somatosensory cortex and the dorsolateral and the dorsal to rostral anterior cingulate cortex, then you feel pain. So this is a very easy way to quantify it, and this correlates with the pain intensity. The correlation is not very high, but it's a very simple way of looking at whether there is pain or not. Now then the question, of course, is, well, if this balance, how can we, where does it start? Where does the imbalance start? So if you look at healthy controls and compare it to patients with pain, and you just take the somatosensory cortices as proxy for the lateral pathway, the dorsal anterior cingulate as a proxy for the medial pathway, and the pre-general anterior cingulate as a proxy for the descending pathway, then you can look at the functional connectivity in comparison to healthy controls. And what you see, interestingly, is that there is less functional connectivity between those 3 pathways, meaning that they don't communicate. And if they don't communicate, of course, you can't create a balance. If you can't create a balance, that will result in pain, probably with the better safe than sorry approach, where the brain says, well, if I don't get the information that I need, it's probably safer to create pain than not to create pain, because it might be salient. So this is interesting, because if you then use spinal cord stimulation, so where you implant an electrode on the spinal cord to treat the pain, then what you see is that those areas start to communicate again, and that can reinstall a balance to then get rid of the pain. So basically, pain can be conceived of as a balance between those 2 areas in relationship to the descending pain inhibitory pathway. But of course, the problem with this is we know then that pain is a lack of communication between the 3 principal pain pathways, but where's the trigger, where's the problem? And so for that, you can use effective connectivity. And if you compare healthy controls to patients with neuropathic pain, in healthy controls, the information flow goes from the pre-general anterior cingulate, so from the pain inhibitory pathway to the somatosensory cortex, so we hypothesize it's inhibitory, as well as to the dorsal anterior cingulate cortex. In neuropathic pain, what you see is that the information flow actually goes from the dorsal anterior cingulate, and we assume it's inhibitory as well, to the pre-general. So in our normal state, we constantly inhibit painful stimuli, both in the lateral and the medial pathway, whereas in neuropathic pain, it's the salience network that inhibits this pain suppression. And if you then use spinal cord stimulation, again, what you see is that this abnormal information flow actually normalizes, and that is associated with pain inhibition. So from this concept, you can say that chronic neuropathic pain is actually an overactivity of, well, not overactivity, an over information flow from the salience network to the inhibitory network, and that we should target this if we want to get rid of the pain. Now, if the brain constantly makes predictions, then of course we want to know where are the predictions generated and where are the prediction errors generated. And Donoso, in a very beautiful paper written in Science a couple of years ago, suggests that the way the brain works, the brain makes multiple predictions at the same time. And these predictions are computed in the pre-general anterior cingulate cortex, and the alternative predictions in the dorsolateral prefrontal cortex. So you make predictions and alternative predictions in the dorsolateral prefrontal cortex. And as long as the brain computes that this prediction is correct or correct enough, that will prevail, and the dorsolateral prefrontal cortex will just compute the alternatives. Now, when the reliability of the current prediction is decreased, then the dorsal anterior cingulate cortex will say, okay, now we have to shift, and what's computed in the dorsolateral prefrontal cortex becomes the new actor, or becomes the new current prediction, and then the ventrolateral prefrontal cortex will actually reject what it is, what's the current strategy, which could be having no pain. And then the ventral striatum, or the nucleus accumbens, just confirms that the pain becomes the new actor, meaning that the pain becomes, for example, part of who you are. So this looks at the pregenital anterior cingulate and the dorsolateral cortex from a predictive point of view, where current strategies or current predictions are encoded in the pregenital anterior cingulate cortex, and what the dorsolateral prefrontal cortex does is just computing potential alternatives. So painful state could be here, and then the dorsolateral prefrontal cortex just says, well, there could be pain as well. And if it becomes chronic, then the information computation here will shift to the pregenital anterior cingulate cortex. Now, prediction errors tend to be encoded, unsurprisingly, in the anterior insula and dorsolateral prefrontal cortex. So in the anterior insula, which is part of your salience network, so what does that mean? It probably just means that if we make a prediction error, by definition, it's going to be salient. It's going to be behaviorally relevant because we predicted something wrong, and therefore we might have to do something about it. And the dorsolateral prefrontal cortex is just that if the prediction is wrong, then the dorsolateral prefrontal cortex, which computes the alternatives, should also know of it, so that it could use it as a new prediction. Now, these areas then connect to, unsurprisingly, the default mode network, and as you can see here in blue, as well as the central executive network. So if we try to make sense of it, what it suggests is that our predictions are generated in the pregenital anterior cingulate cortex when we're at the resting state. When there is something happening, your phone goes off or somebody calls your name, then the prediction of what you're listening to me is being disrupted, and the prediction error will be computed in the salience network, just telling you, well, there's something more important than listening to me. But once you are, and this will then generate activity in the emotional network to create a priority mode to start listening to the person who calls you or who shouts fire. But once you're doing something, then the predictions will not come from the salience network, from the default mode network. The predictions might actually come from the central executive network, so that your goal-oriented behavior is constantly being updated based on what you get as a feedback. So then the question is, that's more of the anatomy. So the anatomy is relatively simple. At rest, your default mode network makes predictions. Your salience network represents prediction errors, and that's why it's called the salience network. And once you start engaging into trying to orient your behavior towards the salient event, then the predictions will come not from the default mode, but from the central executive mode. But the question is, how is that computed in different frequency bands? Because what we see is that the different frequency bands are all correlated. So there has to be some kind of interaction or relation between all those frequency bands, because if they would all be completely independently generated, then it's less likely that there is some kind of structure in between the frequency bands. So from a practical point of view, we do not make only one kind of predictions, we make two kinds of predictions. One is the intention, and the intentional prediction is likely made in theta, and then the updating is performed in delta, and the prediction error in gamma. But if you intend, for example, they ask you to look at a screen in a go, no-go task, then the intention, of course, might be to look at whatever the task is, but then there's also a sensory prediction, whether you will see the image that is going to be looked at, and these predictions come in beta, the updating in alpha, and the prediction error in gamma. So if you look at this was a visual experiment. About 500 to 400 milliseconds before you will start seeing something on the screen, you get an early prediction in theta. And then the sensory prediction is coming closer to when the stimulus is being presented, and that comes in beta. So you've got an early intentional prediction of what you want to do, and then that will create a sensory prediction that comes a little bit later and is presented in beta. So from a practical point of view, it tends to start in the parietal area, then goes to the pregenual anterior cingulate cortex where you make predictions, and in the dorsolateral prefrontal cortex where you make alternative predictions for the alternative possibilities of what's going to happen. Now, the sensory predictions are encoded in beta, and they tend to come in the upper layers, and the upper layers is where the information comes from other parts of the brain, like from the visual. If you record it in the sensory cortex, it will be visual, auditory cortex, etc. And the prediction errors come from the periphery, and they will end up in layer 4 predominantly, because that's where the input is. So there is a layer-specific differentiation in the activation of beta and gamma. Now, for all sensory predictions, gamma is, they are all encoded by beta, and gamma reflects the prediction error, whether it's auditory, visual, somatosensory, etc. So conceptually, that then means that we have that the different frequencies that we look at from a Bayesian point of view might all have different functions. And for example, the alpha frequency might reflect the reliability of the prediction, what's also called precision. So if we bring this back to the concept of the Bayesian brain, then our prior belief is encoded in the prior belief which generates the prediction is encoded in theta for intentional predictions, making what am I going to do, and that results in sensory predictions, that what are you going to encounter, and in beta. The evidence, if it's wrong, then is reflected in theta, and the updating in alpha for sensory predictions and delta for intentional predictions. And ultimately, what we perceive is then linked to a combination of the prior belief, the prediction, and the evidence, and that's where cross-frequency coupling becomes important. So the cross-frequency coupling, from a conceptual point of view, is nothing more than a way of combining predictions and prediction errors. So if we then look at the 1 over f or 1 over f squared structure, then predictions are created in intentional predictions in theta, and sensory predictions in beta activity. The reliability of the predictions, intentional predictions, come in delta, and in alpha for sensory predictions, and the prediction errors in general in gamma. So every frequency band then has a different function, which makes sense, because why would we have different frequency bands if if they don't have a specific function. So this has been looked at, that you get predominantly gamma and unpredicted or mispredicted stimuli, beta if you have predicted stimuli, and this has been already suggested a long time ago, where beta was considered a status quo, and a status quo just means, well, prediction is right, there's no prediction error. And if you have a mal-predicted stimulus, you get coupling of beta and gamma, and so that's again where you get cross-frequency coupling. Now, cross-frequency coupling is a little bit of a difficult concept, because you can couple two or even more frequencies in a hierarchical way in multiple ways. So you can cross-frequency couple power to power, but you can also cross-frequency couple phase to phase. You can do phase to frequency, phase to power. So there's lots of way how different frequencies can be coupled. But the most commonly used one is where the phase of the lower frequency becomes coupled to the amplitude of the higher frequency. And so the phase amplitude coupling is mostly studied. And this makes sense in that you can then conceive of the lower frequency as a kind of a carrier wave, just like a radio signal, and the information on top then either says it's a prediction error in gamma, or it's a prediction, and then the lower frequencies might just be the carrier wave that transmit the prediction error or the prediction throughout the brain, so the entire brain knows there is a prediction error or there is a prediction. So from a practical point of view, there is one thing to take into account, that if you look at phase synchronization, there is two components to it. One is the instantaneous phase synchronization, and this can also be related to volume conduction. So in general, we throw this away, we throw this out, and we only keep the lagged phase synchronization. But with throwing out the instantaneous, we actually also throw out information. Because if you have a central, let's say a thalamic generator that sends information to multiple parts of the brain, then you get instantaneous phase synchronization. But by throwing this out in our computations, we actually also throw out important information. But it is ultimately to prevent false positive connectivity, functional connectivity, by volume conduction. And this cross-frequency coupling changes. So when you have two networks and you learn something, then the cross-frequency coupling between those two networks can change. And so cross-frequency coupling ultimately is also a part of functional connectivity. It becomes a little bit more complicated in the sense that from a physiological point of view, you can have theta and gamma coupling if you pull something from memory in theta, and then you add a prediction error to it, and then you got theta gamma coupling. But this is physiological, this is normal. On the other hand, you also have pathological theta gamma coupling when, and this is called Thalamocortical Dysrhythmia, so where actually the theta is not theta, it's slowed alpha. And slowed up, we call it theta because of definition, that anything between 4 and 7 hertz we call theta, but actually it's not theta, it's slowed alpha, because the generator is in the thalamus and is not in the memory system. So theta gamma nesting can be physiological, but it can also be pathological, and so we should not blindly treat any theta gamma coupling, because you will also get treat then physiological activity. So the idea could that be, if you look, and this is probably something that Jay knows a lot better than I, if you look at how, at the morphology of the wave, then this theta could actually, if it looks more like a nice sinusoidal, it might actually be slowed alpha. And what is important that if you look at this cross-frequency coupling, for example, theta gamma, coming from the hippocampus or parahippocampus, that this can reflect something that is relevant. For example, here, this cross-frequency coupling of theta and theta gamma correlates with the loudness of the perceived tinnitus, which is the sound is probably comes from memory, and how loud it is perceived depends on how big the prediction error is. But what's very important is it's not there all the time, and actually the loudness correlates with the percentage of the time that you have this theta gamma coupling, and not just always. And this might be a way of saying, well, I don't see any theta gamma coupling if you just record it. Well, that's because it's not there all the time. But the more it's there, the louder the tinnitus seems to be. Now, physiologically, you can have alpha gamma nesting or coupling as well. If from the thalamus to the cortex, that is related to attention. And then the question, of course, is can alpha also be accelerated theta? In the sense that when theta speeds up, then you might get pathological alpha gamma coupling as well. So physiological, you have the thalamus that generates alpha, and on top of that you just have a prediction error which is going to be in gamma. But then the question is whether this wave, which looks more like theta but comes in frequencies that we call alpha, might actually also be accelerated theta. I don't know if that even exists, but theoretically it could. So if we summarize that, then theta activity in itself could be conceived of as a carrier wave coming from memory, but theta can also be slowed alpha if it comes from the thalamus. And alpha can be a carrier wave generated in the thalamus. Hypothetically, it could be accelerated theta as well. Beta then just reflects a sensory prediction, and gamma a prediction error. And that leads to the fact that what we call thalamocortical dysrhythmia is physiologically, thalamocortical rhythms, cross-frequency coupling, can be physiological and or pathological, and this is especially important for theta gamma, where theta gamma coming from the memory system is purely physiological, but if it comes from the thalamus, it's actually slowed alpha and it may be pathological. So if we look at that from for tinnitus and pain, then we can look at the different networks, but we can also look in more detail whether we find this theta gamma coupling. So Rodolfo Llinas, who came up with the concept, suggested that if you have sensory deafferentation, so a lack of sensory input, then what will happen is that the thalamus will slow down from alpha to theta because there's just less information processing going on, and we don't need this high frequency. Now this lower frequency, this slow down alpha is then relayed to the cortex, and you will find a little blob in the cortex which does not follow the resting state alpha, but it will shift to a slower frequency, which is theta or sometimes even delta. This will then result, because it's slowing down, in less lateral inhibition, which is GABA-A mediated, and you will get a halo of surrounding gamma band activity, and this is then common depending on the pathology. So Rodolfo Llinas used magnetoencephalography, and when he found this theta gamma coupling in the somatosensory cortex, it meant the patient was perceiving pain. When it was in the auditory cortex, the patient was perceiving sound or tinnitus. So it's actually very easy to detect. You just do a power to frequency analysis. In blue, you see the normal alpha peak on the 1/f curve. and then when the peak slows down to theta and you get an increase in beta or gamma, then this is the signature of thalamocortical dysrhythmia. So it's actually very easy to detect. Now, when you look at pain and tinnitus, which are both called thalamocortical dysrhythmias in the original paper, as is depression, as is Parkinson's disease, then it's like I mentioned, the percentage of the time that theta-gamma coupling is present relates to the loudness of the tinnitus. Then the same can be said for pain. So this is a beautiful quote from de Saint-Exupéry, who said that it's the time that you waste on your rose that makes your rose so important. So if the time of this coupling increases, then that might actually be pathological, because normally this theta-gamma coupling waxes and wanes and is not there all the time. So if you can record it on a 5-minute or 10-minute meeting, that means that it is there most of the time. So when we did a microstate analysis of patients with tinnitus and pain, what we found is that for both tinnitus here and pain, in comparison to healthy controls, the third cluster actually was pathological and very different from healthy controls. And if you look at it, it's interesting. It's the anterior temporal area, which is part of your default mode. As I mentioned yesterday, when tinnitus and pain become chronic, then they link to the anterior temporal area, external temporal area. And if you look at the frequency composition, it is theta and delta that's increased, as well as gamma. So this, whichever way you look at it, this theta gamma or delta gamma coupling does come back. So, but this is from EEG recordings. The question is, if you put an electrode in the brain, can you also record it? And this is for example, a patient who's 36 years old, has intractable tinnitus, has tried basically everything that's available on the market. It's perceived as very loud. She has an auditory dip at 6,000 hertz and a tinnitus pitch at 6,000 hertz, which means that they are related. So it's probably going to be a filling in mechanism, which is compatible with the thalamocortical dysrhythmia. When we do TMS targeting the area on fMRI, she has a 90% reduction, and so because that's only very short lasting, an electrode is implanted. So when you then record from the electrode itself, this is the area that we stimulate blindly. It's just trial and error, where you program the electrodes to find the best tinnitus suppression. And if you then basically fuse the postoperative CT with the preoperative fMRI, then the target that was blindly programmed actually correlates with the bald spot, which is interesting because that would suggest that you can pick up thalamocortical dysrhythmia by just doing an fMRI. Now, if you then record in a bipolar way, then without tinnitus, there is not a specific signature, but when there is tinnitus, then you see a theta peak coming up, but only on the area that correlates with the gamma spot, and that has a benefit because on the other recordings you have the normal alpha peak. So you can record it directly from the brain, which suggests that it's probably not just an invention, but it might be true. And if you combine the areas, then you do see that in most of the patients. Now, what's interesting is that the gamma activity actually correlates with the bald spot, because the further away you go from the target area, the lower the gamma. So from a practical point of view, this bald that you see actually might be another way, rather than EEG, of looking at thalamocortical dysrhythmia, at least at the gamma activity. And if you do if you do an autocorrelation, then what you see is at the area of stimulation, you see theta gamma correlation, which you don't see at the areas that are not related to the tinnitus, and you find this at the group level as well. So even from implanted electrodes, you can find this thalamocortical dysrhythmia. And you can find the same thing in pain. This is a lady who had multiple surgeries, and actually she came because she was always driving her bicycle into the ditch, or when she walked through the door, she would also hit the pole, and she had a phantom eye on her cheek. And she had anesthesia dolorosa, so she had no feeling of her forehead, but painful area. So when we did an fMRI, we found a target to implant the electrodes, but then the pain came back after some more surgery. And because you couldn't do an fMRI anymore, we did a PET scan that we fused with the fMRI. And this was the old target. And these are new areas that were not there. So we implanted 2 more electrodes. And what you see is a small theta peak extra on the alpha area. And when we stimulate on the older, we can improve the pain. But when we target the new area, then we also improve the pain, but only half. And when we activate both, then you get a more pain reduction rather than what you get with the implanted electrodes. And then the question, of course, is the bald spot also related to this theta gamma correlation? And when you increase, if this is your image and you just increase the statistical threshold, then what you get is that indeed this area correlates with the lower electrodes, and the lower electrodes are actually the ones, the ones where you do see a theta gamma or a theta beta activity. So yes, with implanted electrodes, you seem to find the same areas, and if you increase the threshold, basically it correlates with the area, the bold area correlates with the area where you do see the theta gamma activity on the recordings. But these are all individual cases, and the question is this generalizable? Can we generalize this? And for that we use the support vector machine learning, where we looked at different parts of different regions of interest that we know are involved in tinnitus, and using just a purely data-driven approach, what we could find is that only based on the EEG, we have 88% accuracy of detecting tinnitus, 93 for pain, 94 for Parkinson. Depression is more difficult, only an accuracy of 75%. So yeah, you can detect it in a purely data-driven way. When a patient comes in, you just do an EEG, and then you have close to 90% accuracy of detecting either tinnitus, pain, Parkinson's disease. Of course, Parkinson's is easier to detect clinically, but also just using an EEG. So most likely it does exist. Otherwise, in a purely data-driven approach, we would not be able to detect it. So what you find in those thalamocortical dysrhythmias is interesting. You have a common beta activity in the anterior cingulate cortex, as well as the hippocampus parahippocampal area. That's what they all have in common. So whether you have tinnitus, pain, Parkinson's disease, depression, you have this this beta activity in the dorsanterior cingulate cortex, as well as in the parahippocampus. Now then, to know which kind of thalamocortical dysrhythmia you have, you then look at the theta gamma or the theta beta coupling, and if it's in the auditory cortex, it's tinnitus. If it's in the sensory cortex, it's pain. If it's in motor cortex, it's Parkinson. And if it's in the subgenual anterior cingulate cortex, then it's going to be depression. So based on what the beta activity is connected to, you get a different phenomenological expression, being pain, tinnitus, Parkinson, or depression. But then, of course, the question is, how does this beta correlate with the theta and the gamma activity? Because they are different frequencies. And furthermore, the more theta-gamma coupling you have, the more intense the pain, the louder the tinnitus, the more deep the depression. So the more theta-gamma coupling you have, the more intense the symptom becomes. But the question, of course, then is how can this beta activity, which they all have, then relate to the theta-gamma? And when I was looking at Neil Grossman's device, where he uses frequency mixing and temporal inference stimulation. So what he does is he has two stimulators. One runs at, let's say, at 2000 hertz, and the other one runs at 2010 hertz. When on the area where they mix, then you get 10 hertz. So a difference between the two, as well as 4000 and 10 hertz. So you get frequency mixing where the two different frequencies meet. Now, if that's the case for electrical stimulation, maybe it's the same for brain activity. And so you can imagine that if you mix two beta frequencies, let's say 20 and 25 hertz, that the sum is 45 hertz, which is gamma, and the subtraction is 5 hertz, which is theta. And so the beta, if you have two different beta frequencies, then they can, by mixing, you can create thalamocortical dysrhythmia. And this could explain how the beta activity in the anterior cingulate cortex and the hippocampus or parahippocampus correlates then with the theta gamma in the different sensory cortices. Rodolfo Lina suggested that actually this theta gamma activity correlates to bursting and burst firing at a single cell level, and this burst firing has been shown in pain, has been shown in tinnitus, has been shown in slow wave epilepsy, has been shown in Parkinson's disease and in the Habenula depression. So most likely what we record as local field potentials or on EEG or an MEG correlates with burst firing frequencies that is common to all these thalamocortical dysrhythmias. Now, thalamocortical dysrhythmia then has been linked to this calcium channel problems, because what you get in normal tonic firing is sodium potassium changes that create tonic firing. But in burst firing, you have an influx of calcium via T channels and often an outflux via L channels. And so Rodolfo Lina suggested that actually it's the problem of the calcium influx via the T channels that causes this bursting, and this bursting then relates to the oscillations that we record with EEG or MEG. Now, thalamocortical dysrhythmias have been described as pain, tinnitus, Parkinson's disease, depression, and slow wave epilepsy. But there is another group of pathologies which are called reward deficiency syndrome. And this has been described by Bloom and been linked to genetic polymorphism, especially of the dopamine D2 receptor. And they come in also in different kinds. So you've got addictive behaviors as one of the reward syndromes. You've got impulsive behaviors like ADHD, Tourette syndrome, and autism. And then you've got the obsessive compulsive behaviors, but also personality disorders as expressions of a reward deficiency syndrome. And the question, of course, is, are they related? Or can we expand this concept of thalamocortical dysrhythmia also to the reward deficiency syndromes? Now, the idea here is that a thalamocortical dysrhythmia is the consequence of a lack of input in the sensory motor domain, and that reward deficiency syndromes are caused by a lack of input in the autonomic or social domain. But what's very interesting is if your L channels, which are associated with those reward deficiency syndrome, become dysfunctional, actually your T channels take over, and your T channels are going to modify your dopamine D2 receptors, which are the hallmark of the reward deficiency syndrome. So this then suggests that thalamocortical dysrhythmia might be the consequence of deprivation in sensory, motor, and emotional domain caused by a T-channel dysfunction, and that reward deficiency syndrome might actually be related to autonomic deprivation or social deprivation via L-channel dysfunction. And if the L-channel dysfunctions, then the T-channel might take over and then modify the dopamine D2 receptor function, which is the hallmark of the reward deficiency syndrome. If that's the case, then we should find theta gamma abnormalities also in reward deficiency syndromes, and this is what you find in alcohol addiction, in OCD, as well as in schizophrenia, as well as in ADHD. So yes, you do find this abnormal response, which is just the way the brain responds to deprivation of input, also in the reward deficiency syndromes. Now, if that's the case, then you would expect that if you take reward deficiency syndromes and thalamocortical dysrhythmias and you look at what they have in common, that there should be something in common if they have a similar underlying pathophysiology. So if you do a conjunction analysis of tinnitus, pain, depression, and Parkinson's disease, that's what you get. And this is what we published. But if you do a conjunction analysis of the reward deficiency syndrome, so ADHD, alcohol addiction, food addiction, and OCD, you do see that you get a theta frequency band in the dorsolateral prefrontal cortex, as well as the pregeneral anterior cingulate cortex, and associated with beta activity in the dorsal anterior cingulate, which is what you also find in reward thalamocortical dysrhythmias. Now, if you then do a conjunction analysis of all these pathologies, meaning tinnitus, pain, depression, Parkinson, ADHD, alcohol addiction, food addiction, and OCD, what you find is what they all have in common is this theta activity in the posterior cingulate and beta activity in the dorsal anterior cingulate. And there is a difference between thalamocortical dysrhythmias and reward deficiency syndromes in the pregeneral anterior cingulate. So conceptually, what they all have in common is that patients suffer, because otherwise we would not have seen them in the clinic, and that there is a difference between the reward deficiency syndromes and thalamocortical dysrhythmias and the pregeneral anterior cingulate, where in one theta is increased and in the other theta is decreased, but they ultimately lead to thalamocortical dysrhythmia. So if we now zoom in a little bit more in that, then the theta gamma activity in pain and tinnitus, which are two thalamocortical dysrhythmias, in tinnitus, what you find is theta activity in the pregeneral anterior cingulate, an increase. Basically, if theta is increased, it suggests that, conceptually at least, that the theta here it's not alpha, so you can conceive of it in a kind of simplistic way, that the increased theta represents that the pregeneral is kind of asleep. That's the way Rodolfo Llena suggested it. So that the pregeneral anterior cingulate is asleep because there is more theta rather than alpha, and that the inhibitory function is dysfunctional, and that's why you get tinnitus, but also why you get pain. So it's common between tinnitus and pain is that there is a lack of inhibition. And there is increased gamma activity in the in tinnitus in the auditory areas, and in pain in the somatosensory areas. But if you do a conjunction analysis, something intriguing pops up, is that what tinnitus and pain have in common in theta is, of course, this pregeneral anterior cingulate, meaning the brake doesn't work very well, and that's why you get hyperactivity, so you get constant pain and constant tinnitus. But what's interesting is what tinnitus and pain have in common is changes in the auditory cortex and the somatosensory cortex. Now that means that if you have thalamocortical dysrhythmia associated with tinnitus, you also have it in the somatosensory cortex. And then, of course, the question arises, yeah, but why would that be? Why would our brain create also increased gamma and increased theta in the somatosensory cortex in tinnitus and the other way around. And this could be related to what you can call the duck test, is that for our brain to know what's really out there, it uses multiple senses. So when you listen to me, you get auditory input, but you will also look at my lips, and that has to be coherent, that has to be congruent. Otherwise, you find that just gives more proof to the brain that if it flies like a duck, if it looks like a duck, if it behaves like a duck, it's most likely going to be a duck. And this is what our brain might actually be doing by pulling multisensory information to make sure that what it predicts to be there in the world is also there. Now, but this creates a problem, because it means that just based on activity, we can't tell whether it's going to, the Thalamocortical Dysrhythmia is going to be pain, is going to be tinnitus. And so you can then look at connectivity. Now, what you see in functional connectivity is that there is less functional connectivity going from the pregenual to the auditory cortex, but also to the somatosensory cortex in tinnitus, and the same in pain. So functional connectivity doesn't help us either, because in a conjunction analysis between the two for functional connectivity, the pregenual doesn't inhibit the auditory and doesn't inhibit the somatosensory cortex. So functional connectivity doesn't help us either, like activity. And then if you look at cross-frequency coupling, then the theta-gamma coupling is pathological both in the somatosensory cortex and the auditory cortex for both tinnitus and pain. So that doesn't help us either. So then the question is, well, how does the brain then give only tinnitus or only pain if activity is the same, if functional connectivity is the same, and if cross-frequency coupling is the same? Well, the difference is in effective connectivity. The effective connectivity is different, and remember that that in pain, the effective connectivity is different, especially between the dorsal anterior cingulate and the pregenual anterior cingulate. And so how we perceive either tinnitus or pain depends on the effective connectivity, not on the activity, not on the functional connectivity, not even on cross-frequency coupling. And it's the interaction between the pregenual anterior cingulate cortex and the parahippocampus and auditory and somatosensory cortex where the difference arises. And so in tinnitus, what you have is that the parahippocampus pulls the missing sound information, sends it to the auditory cortex, also sends it to the somatosensory cortex for the duck test, so that the brain knows how the lips should behave. But what's interesting is that the auditory cortex confirms this and sends information back to the parahippocampus, but not the somatosensory cortex. And in pain, you find the opposite. So the parahippocampus pulls the painful information, sends it to the somatosensory cortex, and the somatosensory cortex sends it back. So it's a kind of a vicious loop where this is in gamma activity, so where the prediction error basically goes from the parahippocampus to the somatosensory cortex and back, and this might actually be the trigger for people to maintain the tinnitus if it's between parahippocampus and auditory cortex, and between parahippocampus and somatosensory cortex will then result in pain. And this might also explain that if you put electrodes, these are patients that are implanted with electrodes on the auditory cortex, and when we just did a whole brain analysis looking at the difference between responders and non-responders, we were surprised that there was no difference in the auditory cortex, because that's where we implanted the electrodes, but the difference was in beta 3 and gamma in the parahippocampus and hippocampus. So this is very difficult to explain because the electrodes are there, but when you look at connectivity, basically it's the beta 3 and theta connectivity between the auditory cortex where the electrodes are and the parahippocampus, which is in keeping that we're actually trying to disrupt this vicious loop of information flow from parahippocampus, the auditory cortex, back to the parahippocampus. And if you have good connectivity, then you can get to the parahippocampus where the auditory information is pulled from. If there is no connectivity, then the signal just stays in the auditory cortex and you won't get a benefit conceptually. So if we summarize all that, then thalamocortical dysrhythmia is a common pathophysiological mechanism that is involved in what are the traditional thalamocortical dysrhythmias like pain, tinnitus, depression, and Parkinson's disease, but also in reward deficiency syndromes like ADHD, OCD, schizophrenia, and addiction. So the brain actually uses a similar mechanism in trying to solve a problem by slowing down alpha and to theta activity, and this because of a decrease in gamma and GABA A mediated lateral inhibition becomes coupled to gamma activity in a constant way, and that's why we can pick it up with EEG. Otherwise, the theta gamma coupling physiologically then is very short lasting, and we might not pick it up on a static EEG. So the idea is then that the lack of sensory, cognitive, emotional, or autonomic input results in slowing down of the alpha to theta with the surrounding gamma, which just represents a prediction error. And this results in functional connectivity with the parahippocampus, so that the lack of input is being compensated for by what was stored in memory before, that in this specific context should be relevant, and so the brain will just fill it in from the parahippocampus by using theta activities that then becomes coupled to the gamma activity. But interestingly, the theta gamma activity is not only restricted to the area of that is associated with the symptoms. So you have thalamocortical dysrhythmia in both the somatosensory cortex, auditory cortex, visual cortex, and vestibular cortex, but not in the chemical senses, so not in the olfactory and gustatory cortex. There you don't find it. And in order to know then which, and that is probably just to make sure that the interpretation fulfills the duck test, basically, but and that the pregenual anterior cingulate cortex uses theta to increase the salience of the missing input, and that's why we keep on perceiving it in a constant way rather than habituating to it. So from a practical point of view, the thalamocortical dysrhythmia is a whole kind of whole brain mechanism, and it's the effective connectivity that determines which kind of thalamocortical dysrhythmia you will perceive, which also means that if we want to treat it, then probably we should disrupt the connectivity between the parahippocampus and the somatosensory cortex, or if we want to treat pain and tinnitus and other pathologies, then we should go to multiple area targeting rather than one single area, because if you just target one single area, the other thalamocortical dysrhythmias might just maintain it. And therefore, we will do a study where we target visual cortex, auditory cortex, somatosensory cortex, and vestibular cortex with noise to disrupt the connectivity to the parahippocampus, rather than what we've been doing now is just target the auditory cortex for tinnitus, the somatosensory cortex for pain, and the visual cortex for visual snow, which is another kind of thalamocortical dysrhythmia, because based on these data, it does not make sense, because it will just, the pain or tinnitus might be maintained by the information flow coming from the others that send information to the parahippocampus, at least in the EEGs. So better understanding thalamocortical dysrhythmia can actually help us in designing new treatments to treat, whether it's going uniquely from disrupting parahippocampal auditory cortex information flow, or by using a multiple sensory cortex stimulation. And with that, I hope I've given you some more insights in why thalamocortical dysrhythmia is important.
So, Dirk, I don't know if you remember, but just before you published in Nature, I gave you a call and asked you where that manuscript we had talked about was published, and that you said it hadn't been published yet. It's going to be published tomorrow in Nature. I had actually worked with a neurosurgeon for a period of time, telling him whether I saw thalamocortical dysrhythmia or not. And his success rate in surgery for chronic pain went from 50% success, which doesn't sound very good, but if you've got chronic pain and you have a half a chance, apparently you stand in line. He went up to 80%. The ones who didn't have thalamocortical dysrhythmia had beta spindles, excess beta in the somatosensory cortex, which may be the 20-25 giving you the dysrhythmia without seeing it. But all we looked for was the component analysis. And if the component had a theta peak, slowed alpha into the theta band, and a gamma peak in it, both in the same component, and it was from the somatosensory cortex, that was the dysrhythmia that they could fix. And again, the others had beta spindles in the somatosensory cortex, and their success went from 50% to 80% just by identifying it.
Which is actually proving that it probably does exist, because if you can use it as a prognostic factor, it does suggest that it's not the imagination of Rodolfo Nunez, but
that is really good luck on that surgeon. Yeah. Thank you for that insight that allowed us to help the surgeon.
Excellent talk. When you're giving two frequencies at 2000 or 2010 and trying to create a binaural of 10 hertz, my question about that for some time has been, does the skull act as like a bone conductor? Do you think that resonant 10 hertz is going to ring out throughout the entire brain, or do you think it's actually going to only happen where those two streams actually mix in the brain?
Well, according to the data from Neil Grossman, it's only happening where they mix, so where the two frequencies. But the beauty of it is that you can go deeper than with the normal stimulation. There is no commercial product yet. I mean, from an implant point of view, but the concept is very intriguing, because depending on the frequency that you ultimately want to use, you can just use 2000 and 2006 or 2000 and 2004. So you can inject in a deep area where they mix any frequency that you want. And the beauty is also that it should reduce side effects, because the 2000 hertz won't do anything. It's just where they mix that. So according to EEGs, it's only in the area where they mix.
That was my understanding of it as well. So the follow-up question would be, for the pink noise that you're using, are you still using the 100 to 600 range, or are you guys using anything different?
No, so now for a pink noise, we go from 0.1 hertz, so way lower frequency, to about 100 hertz. So we only go to the lower frequency, but we extended it in the infraslow area because we see it in humans that you should be able to go to 0.01 hertz, but that is maybe not for you, but from an engineering point of view, it makes it more difficult.
Yeah.
Also, so that's why we settled from 0.1 to 100 hertz for the pink noise.
Cool. Thank you.
And the reason to go to 0.1 is because the calcium waves that trigger the bursting, which then triggers the thalamocortical dysrhythmia, are coming at these infraslow frequencies. And so theoretically, it would allow us to not only get to the neuronal component, but also to the glial component.
Thank you.
Morning. I remember hearing Bloom years ago, I think at an AAPB conference, and he talked, I guess, that reward deficient syndrome came from a lack of or extra A1 allele gene.
Yeah.
Okay, so that still holds. And he said the umbrella group of all the addictions included outward things like sex and money and gambling and chocolate. I don't know if he said chocolate, but that's my problem. So any thoughts of like whether that will, all those other issues will be corrected or can maybe corrected?
Well, if Bloom, his concept is correct, then yes. The question is, it has been shown for alcohol. It has not been shown for chocolate, for example, that you also have this Thalamocortical Dysrhythmia caused by. But you can also look at it in a different way. If you find a different allele or polymorphism in chocolate addicts of the L channel coding genes, then most likely it would be. So you can either look at it from a genetic component or you can look at it from an EEG component. But just like Jay said, if you do an EEG and you find it, then the question is, of course, where would you look for? You would hypothetically look for the gustatory cortex, but also to the beta activity, and because there's a double signature. You need to have this beta activity in the hippocampus and dorsal anterior cingulate cortex, and then look for the gustatory cortex to find if you have the theta gamma or delta beta. It could be either of those.
But in research, would you be tracking these other peripheral, addictions? That
Yeah,
have a
well,
hard time
what's
postponing
interesting is if somebody is addicted based on a genetic component, then you often see transfer addiction. So let's say you've got food addiction,
Right.
and you treat it by gastrointestinal surgery, then often they become addicted to something else. So it's kind of an addictive, so your genetic component creates an addictive personality. And of course you can then go to either gambling or to sex or to workaholic kind of behavior or extreme sports or but this transfer addiction is actually just a result of this pathological theta gamma activity that just shifts from one addiction to another addiction.
Okay.
So it could be, and if you look at, for example, craving, which is typically associated, then the craving for alcohol and the craving for food are just adjacent areas in the dorsal anterior cingulate cortex. So you could target that, because craving is one of the three factors that make that addictions return. The other ones being stress and cues. Now, cues you can't really block. Stress actually is associated with a similar area as the craving area, so you can target that with one approach, targeting the anterior cingulate cortex. But we have not seen thalamocortical dysrhythmia in that area. But you do see beta activity in that area that correlates with the craving. But as Nick said yesterday, just reducing the craving is insufficient. The patients have to be willing and wanting to get rid of their addiction.
Right. Thank you.
Hi, I have two questions, one easy, one probably difficult. So let me go through one by one, and please answer one by one. So my first easy question is, I do research on the Fragile X syndrome children, and they show a very typical thalamocortical dysrhythmia pattern, which is lower shifted alpha peak, which is basically the theta, as you said, and higher the power. And my impression of the usefulness of the thalamocortical dysrhythmia concept itself here is limited, because it's like you have a fever, and fever is a very high sensitive phenomenon, right? Whatever strange happened to you, your body increases your body temperature. So this is very sensitive, but it's not specific, right? So I think the standard thalamocortical dysrhythmia concept in the scalp recorded EEG world is high sensitivity low specificity metric. And I don't put much hope in using this in our specific research because we know the cause is Fragile X syndrome, and it's not surprising that thalamocortical dysrhythmia is observed because Fragile X also impacts the general intelligence and stuff. So do you have any advice of the usefulness of the thalamocortical dysrhythmia in this situation?
Yes, so I fully agree, and this is the point I try to make, is that thalamocortical dysrhythmia is just a way of the brain to compensate for a lack of input, whether it's sensory input, emotional input, doesn't matter. But what is unique is the effective connectivity between the parahippocampus and the auditory cortex in tinnitus. So this vicious circle, this is unique. So I fully agree that the thalamocortical dysrhythmia is non-specific because in tinnitus you find a thalamocortical dysrhythmia not only in the auditory cortex, which is what we thought earlier on, but you also find it in the visual cortex, in the vestibular cortex. So you find it everywhere, which conceptually makes sense because if to allow the brain to see, well, it is confirmed by the duct test, but this is unique. So just looking at theta gamma is insufficient. You also have to look at the effective connectivity with the parahippocampus because the sound or the pain is pulled from memory and confirmed by the somatosensory cortex, which just says, give me more of this information. That's why the loop goes in two ways. Whereas in the auditory domain, it doesn't say, give me more information. Otherwise, you would have both tinnitus and pain, which can co-occur. But so this is unique. So I, just like you say, okay, well, there is a fever. Thalamocortical dysrhythmia is like a fever, but then you do extra tests to find where the fever comes from, and that's your effective connectivity measure.
Okay, I have further comments on that, but let me go to the second question because this is more important for me. So my second question concerns more like a generative mechanism of the thalamocortical dysrhythmia. And I recently learned that there was a study on alpha and spindles by Lopez da Silva and Stereate in the 80s and 90s. And just to, give you the brief summary, although you may know this already. The alpha was studied by Lopez da Silva using dogs, and they found that alpha is generated inside the cortical layers, right? So they put the dipole, electric current dipole in the cortex layer study, and they identified that using the awake dogs. And spindle was found and studied by Stereate, and they used cat during anesthesia or deep sleep. And the very misleading thing here is that alpha and spindle has very similar frequency ranges. So basically spindle oscillates in the alpha range. So if you don't know the background information, then alpha and spindle basically look the same. But Lopez da Silva proved that these two things are different. And now the question is, when we observe human alpha, then this is probably the mixture of alpha and spindle. And in my opinion, spindle is more associated with pathological state because it's mainly associated with anesthesia or deep sleep. And in Linus 1999, you cited many times during a presentation, says, this spindle is like a mindless burst mode. And I think this expression is very, interesting expression to identify, this image of how the nature of this spindle, which is different from alpha. And like many researchers identified, alpha is not limited to the occipital so-called alpha rhythm, but low amplitude alpha is everywhere in the brain, and which is not associated with lack of attention or anything. But it's just one of the universal expression of the brain functions. And my hypothesis here is that spindle, in the case of the human, tend to show lower frequencies like 5, 6, actually. So the frequency shift from standard alpha range to the lower alpha, like a pathologically lower alpha range, may be the expression of shifting alpha 2 spindles, but this is just my guess. And do you have any insight in this and general discussion between the spindle versus alpha?
I don't, but Jay might have a good answer to that. Because what Jay has just said is that if we found theta gamma, then
spindles.
they responded to treatment, but if they had beta spindles, then they did not. So there has to be a difference between the two from a physiological and pathological point of view. So Rodolfo Luna suggests that actually this what we record, whether it's with MEG or EEG, is actually the result of bursting activity, not tonic activity. And this has been shown and very nicely presented by Crunelli in a Nature Neuroscience review paper. The bursts that we record as frequency oscillations actually are in a physiological state during awake state. They are irregular. You could see it as a start and stop sign that says this is the information quantum that is being transmitted.
Yeah, we call it the non-stationarity simply.
Yeah. And so when it becomes very rhythmic, it's pathological, or you're in sleep, or you're in, so the rhythmic, so that would be another way, but then you have to go in. You can't record that from the brain itself, well, externally, you have to record inside the brain. So the bursting that we see in all these pathologies is very rhythmic, and that's pathological because a quantum of information is shorter or longer, and this is what Walter Freeman has also shown. The gamma activity is actually the information itself, and the theta, according to Freeman, is the carrier wave. Now, what that has to do with spindling, I will leave over to Jay to answer that question. If it's difficult, it's for Jay to answer.
We'll have to take this up after this evening with cake.
Okay.
Thanks.
Discussions coming with Okay. Great talk. It's like a fire hose. So you'd said that all thalamocortical dysrhythmias have in common beta activity in the dorsal anterior cingulate and the perihippocampal gyrus. And I missed it. I missed what you'd said as to the why. You had a hypothesis. It sounded like it was something about a beat frequency.
So what we recorded is just the beta frequency in general, but now we're doing more detailed analysis and see if what we record in the beta, if there is actually multiple peaks that then correlate with the theta gamma by mixing those frequencies. It is not, it sounds simple, but it's not that simple because everybody has an individual alpha frequency, and the beta frequency might also be different between. So for a group analysis, we might, if they are harmonics, then you might have different two beta frequencies that are different between different individuals. So from a group statistics point of view, it's not that easy. Now, Marco Congedo has suggested to first normalize to create an individual alpha for the whole group that's the same, and then you could do a group statistics on it. So the idea is that the beta activity in the dorsal anterior cingulate correlates with the distress or the suffering, whichever way you want to call it, and that the beta activity in the parahippocampus might actually a representation of what you could call a status quo. So the prediction is just, yes, there has to be sound, there has to be pain, there has to be, and that this is then translated in the sensory cortex to the theta gamma abnormality, just because the frequencies are mixing. That also requires that the connectivity, of course, is going to be from the parahippocampus and from the dorsal anterior cingulate cortex to those. So there is a couple of analyses that we have to do in order to explain it in more detail. But so the parahippocampal beta might be pulling the information as a prediction from the parahippocampus, and the dorsal anterior cingulate might represent more the suffering associated with it. So it's non-specific, it's more likely non-specific.
And they happen simultaneously, you see?
Yes.
Yeah. Interesting. Thanks. Okay, one more question. You said the parameters you use for pink are 0.1 to 100, which is interesting. What do you use for brown? What are your parameters for brown noise when you give it?
Same. So from 0.1 to 100, but the slope is steeper.
Okay. And I can ask one more question? So when you were showing the visualization of a thalamocortical dysrhythmia, I was curious. It was a slope, and it looked like it was either from one electrode or it could have been from an independent component. And you showed a normative, I believe, and then the thalamocortical dysrhythmia on top of it with a higher amplitude gamma range. Now, the way that I learned to read these in ICs was that there's a gamma frequency, a gamma rhythm, rather, that you can track with a peak. And so it was interesting to me to see that it was just a lift in the whole gamma range,
Yes.
and then the relativity piece. So I thought, well, what if you don't have a relative basis?
Yes, so we see that, and I didn't show that, but when we used the support vector machine, we saw that this gamma actually, just like this comes from Rodolfo Yunes' paper, but we found exactly the same. It's not a discrete gamma peak. It's actually the whole band that is increased. Why that is, I don't know, but it's not a discrete gamma peak. It's the whole gamma range that is increased.
Mm-hmm. Okay, thank you. That was great.
Alright, folks, we have a talk by the wonderful Martijn Arns starting at 11. So you have about 35 minutes. Please be ready for that.
It'll give me fewer things to criticize.
Ik moet zeggen, ik voel het vanmorgen wel een beetje onze kleine... De wijn van gisteren, toen ik opstond vanmorgen, dacht ik van tja, we hebben precies toch een glas te veel gedronken.
Hele lange periode.
Ja, maar we hadden niet gegeten, hè. Ik denk dat was hem nou niet gegeten hebben.
Hele gezonde combinatie. We zijn zo geleerd, we leren het nooit.
Ja, we leren het nooit.
Brilliant talk, by the way. Geweldig. Mooi overzicht.
Ja, ik moet... That's good. We didn't say anything bad from anybody, so it's okay.
Can you
good, and maybe if we can just angle it a little bit more
Yeah.
towards you.
Like
You
I
want to
can't.
put this back in your pocket?
Yeah.
And then
I can't see how it's connected,
Yeah.
so maybe you can do it.
I'll do that. 1 sec. Great shoes. Amazing shoes.
Thank you.
All right, let's see. Get this pointed at you. Okay, I think that's better.
All right.
Yeah, so just do some talking.
Yeah. Testing, testing.
Oh my god, it worked.
That's good. Cool. Then, oh, we still have half an hour.
Yeah, we got plenty of time. He ended early somehow.
Yeah.
I'm excited, man. This has been mind-blowing. Dirk's talks are always so well put together.
They're very information dense.
And the thing is, it's like he's not even trying. There's some people who go up and they'll hit you with a lot of information fast, you know.
Mm-hmm.
But it's like just
Yeah. No, I agree.
the subharmonics thing of like the different beta frequencies. I had never thought of, you know, because we always think of it in terms of like the thalamus is the director and the cortex is just doing what it says.
Yeah.
What's up?
Oh, we're trying to check levels. Can you speak, please?
Yeah. Can I testing, testing, 1, 2,
I'm
3.
doing too much talking.
Yeah. Testing.
Thank you.
Okay. Okay.
Anyways,
No, I was thinking, Martijn, that only you can follow Dirk.
yeah.
Oh, I'm not sure.
You have a tough act to follow.
That's some big shoes to fill, I would say. We'll see.
Yeah, Jane and I were talking last night.
And you know what else, Martijn? I always wonder, am I pronouncing your name right? Is it Martijn?
It's normally it's Martijn. Martijn. But Martijn is pretty good.
So say it again.
Martijn.
Martijn.
Martijn. Hein.
Time, like it rhymes with time,
Yeah.
but with an N. Like the tines of a comb, right?
So is Martijn better?
That sounds
yeah,
better.
you got it. No, you got it.
You have to have that French. His is a little more
No, it's Dutch. It's not French.
Dutch, but yeah, I know.
Are you going to be walking around or sitting?
I think I'll walk around.
Okay, cool. Great.
Yeah, that's okay.
So we'll leave these off, so it'll just be the lav mic.
No, that's good.
Yeah?
Cool.
Can I get you anything? Is that your water?
Yeah, I just got one. Is that okay?
Yeah.
Yeah, cool.
It's just that subtle, there's a subtle sound in there, like there's an overtone.
It's a funny language, Dutch.
Yeah, especially, so say for me Gouda.
G-O-D.
The cheese.
Oh, Gouda.
Gouda.
Ja, en Schravenhagen. That's the nameplate.
I love it. You know what I really love in Dutch? Is mealtime, when I get to say, eet smakelijk.
Mm-hmm. Oh.
So automatic.
How are you?
Pretty good myself.
Good. Thank you for coming all the way here and doing this talk. And I'm a provider of TMS. I'm a psychiatrist, and so
Okay.
I've gone through your lecture a few times, and I tried using the heart-brain coupling app,
Okay.
and so it wasn't.
So
able
how
to
is
work.
it?
It wasn't able to work on with my polar. Somehow it just wasn't working. I tried it a few times.
But you have a Polar H10?
Yeah.
It's quite specific to the
Yeah,
Polar you
I
have.
the
But
H10.
okay.
Yeah. And so
And is it not connecting or?
somehow it wasn't reading. It wasn't reading it. And so.
Have you tried resetting it? What you can do is take the battery out, and then there's a way to reset the Polar whereby you can reconnect it again.
Okay.
And usually that's one way to resolve it. But yeah, we've not seen that many problems.
Yeah, okay. So you guys are still using, I wasn't sure if the app is active. I know you guys also have your device that you sell.
No, we're not using a device anymore.
Oh, you don't use that anymore?
So we're mostly relying now only on the Polar, on the H10,
That's so
together with
wonderful
the
that
app,
you
and
have that.
yeah, we're using it prospectively in a lot of clinics right now. So yeah.
Okay, I'll try again and maybe we'll just.
Otherwise, email me. I think I'll connect you to our to Mark, who is more the guy, the sport guy as well.
Yeah.
And I think he has had more of those issues. But I recall sometimes if it doesn't connect well, you can reset it if you follow the Polar instructions and reset the device.
Okay.
Then suddenly it will connect again.
Yeah.
It should be something very simple like that.
Yeah. And I'm meeting with your team next week. Brett, I don't know if you know the salespeople. but NeuroCare
Oh,
Apollo.
NeuroCare, yeah. Yeah, at least I'm no longer involved with NeuroCare,
no,
so,
you're not.
so I've stopped consulting with them since beginning of this year. Yeah.
Oh.
So I still have contact with them, like Stan Miller and other people.
Yeah, Stan's wonderful. Yeah.
But officially, I'm not an advisor anymore. So.
Okay. Okay. So yeah. Well, thank you for your work, and I'm a big fan of yours. You know, your writings and one question. I don't know if you care to think about this right now before you talk, but you know, we use the right posterior prefrontal, like these targets. We use it for I think he calls it the amygdala target. So we use that more for the axiosomatic type symptoms presentations, and we get good results with 1 hertz on the right. And then we do use the Fox anti-correlated target for the more dysphoric with the 10 hertz or ITBS.
Yeah.
And then you guys also have a paper on the proximity to 10 hertz.
I'll talk a lot about it tomorrow.
Yeah.
That's the focus of tomorrow.
Yeah,
and we've got some more extensive data now that we can not only predict it for 10 hertz, but also for 1 hertz and 18 hertz.
Yeah.
So we just analyzed the brain sway data set as well.
Okay.
There we find really exciting results that can really help optimize treatments.
Yeah.
So the frequencies are really targeting a different subgroup. Not as much from a symptom level. I know Sean's paper, of course, about the angiosomatic.
Yeah.
We've looked at it, and I think there was a recent paper last week by Nick Trapp, where they had a very large sample where they randomized people to 5.5 centimeter or the beam target, and there were no differences there. They found some very minor signal and anxiety, but I think it's not something I would expect you to see on the individual level.
Yeah.
And right versus left, I mean, it doesn't harm to do 1 hertz on the right.
Yeah.
But overall, we see the outcomes are quite similar, both for depression and comorbid anxiety.
Yeah.
Again, it doesn't hurt to do 1 hertz on the right, but.
Yeah. And what I notice is if it's not working, I'll try another target, I'll try another frequency, or intensity, and then if it doesn't work, I can't find out ways to get it to work for the non-responders.
One good thing to consider is 1 hertz OFC stimulation. We just had a paper published in brain stimulation, which is now the 3rd in a row, where basically people that are non-responsive to DLPFC TMS, if you cross them over to 1 hertz OFC, which is basically AF8 or FP2, that 30% of the people can still be rescued in that way.
Yeah.
And that's quite significant, I would say.
Yeah. I tried that once with someone, and she had one day where she felt better than she ever felt, but I couldn't replicate that. I couldn't get that to come back.
Okay.
So I tried different intensities. I wonder if is there coupling with the OFC as well as the other markers?
We looked at FP2. FP2 is very painful because we always need 10 hertz stimulation to do the heart-brain coupling.
Okay.
And 10 hertz at FP2 is quite painful.
Yeah.
And we have not seen reliable heart-brain coupling on that side to begin with. So I think it's really a different network that you're targeting with the OFC stimulation. But I think it's very promising. I would maybe try it with some more patients, but we see it definitely makes a big impact for some people.
Yeah.
And getting 30% additional remission, I think is really valuable in that subgroup.
Yeah. I thought Downer had a paper where he mentioned the heart-brain coupling works with 1 hertz or something.
Yeah, I think he looked at the 1 hertz.
Yeah.
The jury is not out on that one. Marina Kaur, she's from Paul Fitzgerald's group, she did 1 hertz as well. She found the opposite, that she would see a heart rate acceleration after 1 hertz. And Jonathan indeed reported something on 1 hertz, but I'm not sure how. I mean, the jury is not out. I think it's a bit opposing results, and we've looked at 1 hertz ourselves as well. We've not been able to find really consistent effects. I think 1 pulse per second is probably not intense enough to really drive the whole network.
Yeah. Are you guys trying different stimulations? Like, so if someone's alpha is a little bit further away from the 10, like trying maybe and training them with the 9.5 hertz stimulation first before we get. Are you guys doing things like that?
We've done that a long time ago, and that's a very natural thought. So a long time ago, and it is published as well, we did alpha peak frequency plus 1 hertz because we thought it was making it more effective. And overall, we did not find any benefit there. If anything, what we found was that 9 hertz TMS was having a completely different effect, being less effective relative to 10 hertz.
Okay.
So that's why we canceled it. So that's why now we're more pursuing. I mean, it would be very natural to think like, okay, individualize your stimulation frequency based on the EEG.
Yeah.
But it means there's a lot of studies on 1 hertz, on 10 hertz, on 20 hertz, but there's no good studies on 9 hertz or 8 hertz TMS. So then you're getting into a more experimental approach. So that's why we more believe in the idea of stratification. And what I'll show tomorrow is that when people have a relatively high alpha frequency above 10 hertz, then 1 hertz TMS on the right is a better choice. If it's very close to 10 hertz, then 10 hertz is your choice left. And if it's very much below, then the best choice is 18 or 20 hertz TMS.
Oh, really? Okay.
So we see that 18 or 20 hertz, opposed to what we hypothesized before, is desynchronizing your alpha to a large degree.
Yeah. Is that your low decile scores? Is that what you
Exactly. So low decile scores will be associated with 18 or 20 hertz.
Okay.
It's a new finding. We're just submitting it right now.
Okay. It doesn't matter if it's a brainwave. The brainwave device is a little bit more.
Exactly. So we looked at BrainsWay. The BrainsWay data was both on H1, H7, and we saw there was no difference. It was identical for both coil types. And we have data from Jonathan's clinic as well, Jonathan Downer, and he did 20 hertz as well, and we could replicate it in his data as well. So it's irrespective of coil design that from what we see right now, which I think is very promising.
Yeah.
Because switching your machine from 10 to 20 hertz is an easy thing to do.
Yeah.
Right?
Yeah.
And if you can still rescue a lot of people that have a low decile score, I think that's going to be beneficial.
Okay. Well, yeah. Thank you. You okay if I take a picture with you?
Yeah, not a problem.
Well, you're famous in the TMS world, so.
Is that true?
Yes, you are.
Okay.
Thank you.
No problem.
Yeah, thanks for all your contributions for us practitioners out there. So,
Well, I mean, that's the aim we have. I mean, there's a lot of more neuroscience which is really fun and interesting, but always the translation to practice is always very difficult. And we're always trying to, I think the Heart-Brain Connected, I think, is the ultimate example of how we like to do research. We want to make it accessible immediately to someone to be able to use it for patients, because a patient is depressed now. They don't have a couple of years to wait until all the research is catching up and be able to do it. So always thinking from a very pragmatic point of view, and how can we already utilize it to make patients benefit straight away.
Yeah. Well, thank you. I'll try it again.
No.
Yeah.
But good to hear that you're using it.
Yeah.
Cool.
Thanks.
Hope you enjoy. work in the beginning.
I have a saying for that. Don't blame me for your dad's success.
I'm not blaming anyone. No, but it was the inspiration from, when we started with the ADHD and had this alpha peak frequency predictor, that's really where it all got started. And I think we now really have a grip on it, on how to use it for multiple treatments.
Folks, please find your seats.
Cool.
We're going to be starting soon. Some way to go from vertical to sitting.
Welcome back, everybody. And we look forward to Martijn's presentation on TMS-Induced Heart-Brain-Coupling, implications for selection, frontal thresholding, and improved clinical outcomes. I'm very excited to hear this presentation because I'm so interested in TMS, so please.
Thank you very much. Well, thanks a lot for being here, and Jay, thanks a lot for the invitation. For me, it's a privilege to be here and see you all coming in to listen here. So I think I'm going to switch gears a little bit. I think I will not be able to throw as many terms as Dirk did in the previous presentation, which I think was phenomenal. I think I will probably stick to only 3 anatomical structures that you'll hear, like the dorsolateral prefrontal cortex, the subgenual ACC, and the vagus nerve. So probably we'll leave it there. So I think there's not many more terms that we'll have to throw in there. So indeed, I think the main focus of the talk will be about TMS. I will briefly talk about EEG, but yeah, that will be very brief because we failed. We could not use the EEG to do what we wanted to do, and that's why I think the main focus of the talk will be on heart-brain coupling, which I think is a very interesting phenomenon. So just to get a kind of impression, is everyone familiar with TMS? Who is not familiar with transcranial magnetic stimulation? Can I see some hands? Wow, everyone is familiar with it. That's a good one. It's a good sign that the TMS is somehow make it. So how many of you are actually doing TMS or involved in a clinic that does TMS? That's fewer, but so hopefully after this talk, I think I will hopefully be able to create some interest that more of you will be more interested to start doing it as well. So when we talk about TMS, and this is a very old photo, this is from when we started with TMS, somewhere around 2006. We had the old-fashioned MagStim device, which was quite a big kind of unit we see over there. And basically we're targeting the dorsolateral prefrontal cortex. So yeah, we started with the treatment, and I had a very naive idea at that point in time. The main interest we had was quantitative EEG, and I'll talk more about it tomorrow and how that relates to TMS. But we thought, like, well, if we're picking up the activity with EEG in this direction, we might very simply feed it back and correct some things with TMS. And it was a very naive idea at that point in time. So that's why we started doing TMS. But when we started doing it, there was not a big need for further personalization because the effectiveness that we saw and the remission rates that we were observing were quite high already. So I think it's been a very powerful technique. And also I think in an analogy, we all know that neurofeedback is still struggling to be accepted, to be seen as an evidence-based treatment. And I think the big difference with TMS is A, very expensive, B, it's frightening. When we received this machine, it took us literally a month before I dared putting it on my head. Because you know you're physically stimulating your brain and there's a potential side effect, which is a seizure. So I think because neurofeedback doesn't have those potential side effects, I think people are more liberal with it. And I think the big difference is everyone in the whole world so far, when they start doing TMS, they all do the same protocol. They aim start stimulating the dorsolateral prefrontal cortex, and not like in neurofeedback, there's almost no clinicians out that say, well, based on your EEG, let's do some TMS here, or let's start doing it there. And we don't see that creative liberty, if you will, with TMS, and that's why I think the results with TMS have been very consistent, and people have been getting quite consistent and good outcomes overall. And that's also why I think it has been regulated and accepted in a much better way. As I think it's maybe also something we can learn and need to apply more to neurofeedback, have better standardization, have better kind of ways of applying it in a standardized fashion. But now back to TMS again. So with TMS, as I show here, we've been mainly targeting the right or the left dorsolateral prefrontal cortex. And there's different stimulation parameters that people have been using. Old-fashioned style is like the conventional TMS is 1 Hertz or 5 Hertz or 10 Hertz. And generally speaking, people would then consider that 1 Hertz is considered more or less inhibitory. And I will show you that's not true, but that's the old-fashioned way of thinking. And everything above 5 Hertz is considered to be more excitatory. There's also a new family of patterned TMS, which is like intermittent theta burst stimulation or theta burst stimulation. And here we see that they're trying to mimic a theta rhythm, which has triplets of 3 bursts at 50 Hertz. And they're modulated in a theta rhythm. And the initial idea was because theta is also the predominant rhythm of the hippocampus, and therefore it should result in more long-term benefit. And so that was the initial idea. Currently we see that both treatments are quite comparable regarding outcomes and long-term outcomes as well. And generally speaking, we always apply like intermittent theta burst stimulation or high-frequency TMS to the left prefrontal cortex. And when we target the right prefrontal cortex, we mainly resort to 1 Hertz TMS. And the old-fashioned idea was still a frontal asymmetry or frontal alpha asymmetry, as you all know it. That was still the idea or the philosophy behind it. At this point in time, we know that there's no diagnostic value of frontal alpha symmetry. But the old-fashioned idea was still that you want to increase activation on the right prefrontal cortex or decrease activation of the left prefrontal cortex. So, and that's still what we're doing to this date. However, this is what I mentioned. The old-fashioned idea is, and this is a very old study. There's a lot of critique to this study, if you will. It's very heterogeneous, etc. But based on this study, they've shown that high-frequency stimulation will increase regional cerebral blood flow. And when you apply 1 Hertz TMS, it should somehow reduce regional cerebral blood flow. I think since then, there's almost no other studies that have confirmed this. So please forget this immediately. But I'm showing this because this is still the background of why and how people interpret how different frequencies impact on the brain. The reason why I say you can forget it is there's a couple of very large studies, and again, you cannot rely on small studies with N's of 10 or 20 people, because if you want to compare 2 treatments and conclude that they are similarly effective, you need very large sample sizes. So this is a study with about 300 people that were randomized to intermittent theta burst stimulation at 10 Hertz. And in this study, they randomized about 300 to 400 people to different types of stimulation. So they looked at left prefrontal high-frequency stimulation. They looked at bilateral 1 Hertz on the right and on the left. And also they looked at right unilateral low frequency. And so hypothetically, if the frontal asymmetry was right, you would expect that the 1 Hertz is fine, the 10 Hertz on the left is fine too, but that the 1 Hertz bilateral stimulation would be less effective because it's counterbalancing that effect basically. And what you can see is that there's no difference at all. So based on these studies, we can conclude that yes, TMS is very effective, but it doesn't matter if you stimulate right or left, and it doesn't matter what kind of frequency that you are using as well. So that's why I think we really have to think, and I think Dirk and other people have talked about it extensively, we have to think about networks. So it's a whole network activation that we're thinking of. This is from Risto Ilmoniemi. I think it's a nice visualization. If you apply one pulse to the left motor cortex, you see it traveling through the whole brain. So we should not expect that when you apply TMS that it's just something that happens in the dorsolateral prefrontal cortex. It's just an entry into a whole functional network that we're trying to activate. And I think that's really an important thing to keep in mind. By the way, if there's questions, please interrupt me. I usually like it to be a bit more interactive, so feel free to ask questions if you will. So when we started doing TMS, we had a very pragmatic point of view because we said, well, we do the TMS and we apply the psychotherapy at the same time. And I could make a very nice story and say that we were really smart and we knew what we were doing, but we were not. This was very pragmatic for reimbursement purposes. We would get reimbursement for the psychotherapy. That's what we would negotiate out. And then we would only add like a €25 fee for the TMS. And I think for those in the US who do TMS go like, what, $25? Because the rate in the US is like $250 to $350 for a session of TMS, which is often only conducted by a technician without the psychotherapy. But that's at least before the FDA approval was there, how we started. And what we observed when we were publishing our first studies was that we thought like, well, the remission rate published is often like 30%, but we're seeing quite high remission rates. So I don't know, what are we doing differently? So after some time, Frank Padberg in Munich really motivated us to start writing this up in order to make it more accessible as well. So we have a large sample, so this is about 200, yes?
What was your assessment procedure? Did that help your outcome?
Can you repeat the question?
What was the assessment procedure and if that improved the outcome? Well, the assessment, at that time we still used the quantitative EEG. And the only thing we did at that point in time, of course, screen for paroxysmal activity because there's the likelihood of a seizure. Currently, we don't do that anymore because the likelihood of a seizure as a result of TMS is lower than getting a seizure as a result of an SSRI. So the likelihood is so low, and if it happens, you're always there. And with an SSRI, people could be anywhere, including sitting in a car. So that was the first screening. The second thing we did is if people would have beta spindles, we thought at that point in time, still based on Jay's work as well, that we thought like, well, that could be potentially easily kindled cortex. So then we would resort to 1 Hertz on the right relative to 10 Hertz on the left. We've looked at it in detail. There were no differences in response rate, whether we would do 1 Hertz on the right or 10 Hertz on the left. So I don't think those things would have explained it in detail. No. So other than that, it was just a combination of standard TMS and also the type of TMS we do. I think in the US, people will say like, well, you're just tickling the brain. We're just doing 1,500 pulses. The US FDA approved protocol is like 3,000 at least. The number of sessions we do on average was 21. Whereas the FDA-approved protocol calls at least for 30 sessions. And so altogether, I think it's quite a mild protocol, and we only do 2-3 sessions a week, and so not the 5 sessions per week as well.
So are you essentially saying that frequency doesn't matter that much?
On the group level, so the question was if does frequency matter or doesn't it? On the group level, and this is an important one because that also bleeds into my talk tomorrow. On the group level, there's no difference if you do 1 Hertz on the right, 10 Hertz on the left, ITBS on the left, 20 Hertz on the left, etc. So on the group level, it doesn't make a difference at all. What I will show you tomorrow, and that's a very recent insight, is that you can use the frequency to optimize someone's likelihood of responding based on the EEG. I'm not going to give away the whole conclusion because that's the talk tomorrow. And that's very recent, and that's just a very recent insight we have based on replicated outcomes as well. But on the group level, for now, the frequency doesn't really matter. No.
Thank you.
So when we looked at these data, so it's 200 people and with effectiveness trials, and remember efficacy is what you evaluate based on a double-blind placebo-controlled trial, but effectiveness, which is considered to be more important than efficacy because effectiveness is what happens in clinical practice. And we know from CBT and other treatments that if you investigate them in a clinical trial, you get great outcomes. But when you throw it at clinicians, the effectiveness basically goes down. So the remission rates are much lower in clinical practice out there relative to doing it in a very controlled trial. So therefore, I think effectiveness data are really important to appreciate what the clinical value in clinical practice will be. So the data is from 3 different clinics, so it's a multi-center approach that we had. And you can nicely see that indeed there's a very nice improvement, and we saw that the response rate was 66% and the remission rate was 56%, and with just 20 to 21 sessions. When we compare that to other open label trials, this is the Australian experience from Paul Fitzgerald, more than 1,000 people, Linda Carpenter, which is the open label continuation of the neuronetics trial, and the Bloomberger, which is basically the ITBS non-inferiority study, we see remission rates around 30 to 40%. And that's basically for any antidepressant treatment that you'll find.
What is the remission rate? What is the remission rate?
Oh, what is remission rate? Yeah. Okay, so there's usually in most studies we talk about response or remission. And response is like, well, how clinically relevant is the improvement, often considered to be a 50% improvement from intake to outtake. But we consider remission to be more important. Remission means that you are below the clinical threshold. That means that you're officially no longer diagnosable as depression. And so the depression is really gone. That's what remission entails. So I think it's a really clinically important variable. And so you can see that the remission rate almost doubled in the work we've done. And of course, I don't think it's really that we're doing something special, but this is simply the combined treatment of combining psychotherapy at the same time with the TMS. So later on, we started understanding this, like this is a meta-analysis where they looked at MRI changes. Dirk?
Yeah. So you say it's related that you do psychotherapy plus TMS. Could it also be that because you only do 2 or 3 sessions, that this might be superior to doing 5 sessions a week? So that the fact that you give less stimulation might actually be beneficial, because in TDCS, the German group has looked at it, and 5 sessions of TDCS actually seems to be less beneficial than 2 or 3 sessions a day. So could something similar also be the case in TMS?
Interesting question. I think, I mean, we know a lot about intensifying TMS. So there's a lot to do currently about accelerated TMS, where people will do 5 times per week, but now also like 2 or 3 sessions per week. And Nolan Williams' work with the SAINT protocol, it's now even 10 sessions per day for 5 days. So 1 week of TMS, and that's what they call accelerated TMS. And they see very good clinical outcomes as well. So generalizing that, and I think Jonathan Downer has some work on it as well, is it the number of pulses or the number of sessions or the number of days? And that seems to suggest it's the number of sessions is really what is effective. So whether you spread them across a couple of weeks or spread them within a week, the remission rates will likely be the same. It has not been investigated that systematically in lower regimes like what we're using, so I cannot rule it out. But I would think that it's probably rather similar rather than the opposite, I think. But it's an interesting thing to consider. Yeah. So in this study, they looked at changes as a result of psychotherapy only. And here we can indeed see that we see changes at least in the rostral anterior cingulate, in the insula, in the inferior frontal gyrus. And rostral anterior cingulate, I will interchangeably refer to the subgenual and the rostral anterior cingulate. I think it depends on the definition, but there's a lot of overlap between the subgenual and the rostral anterior cingulate. And so now we know that when we target the depression network, because this is often considered, these are considered the key hubs in the depression network, of course, overlapping with the default mode network and the executive networks. And we know that if we target the dorsal or the prefrontal cortex, we can get antidepressant results. From Helen Mayberg's work, we know that targeting directly the subgenual, you can get antidepressant effects as well. And we also yesterday heard that vagal nerve stimulation is a quite strong antidepressant treatment as well. And so these are the key hubs, and we now understand if you activate endogenously the subgenual anterior cingulate that's involved in processing emotional content, and at the same time apply the TMS, what fires together, wires together. I think it makes a lot of sense that at least combining them is a very sensible thing to do and increases your remission rates considerably and at no cost. That's the most important thing there.
So is the main effect of stimulation come from stimulating the gray matter or white matter?
From my understanding, it's the gray matter. So you really generate action potentials which are carried down transsynaptically throughout the whole network. Yeah. So when we then look at the remission rate, and I think this is an interesting slide, we have successfully used this slide to convince the insurance companies in the Netherlands to be more lenient about the reimbursement. And here we see the remission rate, response remission rate of psychotherapy monotherapy. Here we can see the response remission rate of a first-line antidepressant treatment from the STAR-D trial. That's the largest trial out there. And here as well we can see if you combine talk therapy and medication, you also have increased response and remission rates. However, a very important thing is that from the STAR-D we have learned that if patients fail one treatment, their subsequent response and remission rate drops and drops and drops. And so after 2 failed treatments, we see that the likelihood of response and remission is about 10 to 15%, which is a very low likelihood of responding. And these were crossed over to different treatments with different modes of action. And so who are the patients that we are treating with TMS? Well, it's these patients. So then relatively speaking, getting response and remission rates either from monotherapy or combined therapy, it's a huge improvement that we're seeing. And that's why we proposed indeed in the Netherlands that we said, well, in the US, I think it's still 2 or 3 failures at least. And we said the patients will need to have failed 2 evidence-based treatments. That can be 2 types of medication, can also be 1 psychotherapy, 1 medication, but also 2 evidence-based psychological treatments. So the Netherlands, I think, is the only country where you could qualify for TMS without having tried a medication, as long as you have tried 2 evidence-based psychotherapies, which I think is really what the data suggests as well, is what's in the interest of the patient. So, of course, we're here, how can we improve clinical outcomes? And I think combining with psychotherapy is one thing, but a very important other question is, where do we target TMS? And when we started doing TMS, we used the 5-centimeter rule. And when I was teaching for neurologists or neurosurgeons, they were always looking like, sorry, what? So you find that area where you find a thumb twitch, and then you move 5 centimeters, that's it? Well, that doesn't sound really precise. Well, no, it doesn't sound precise. But that's what the first FDA approval was based on, and we see that the effectiveness, the response remission, is pretty okay. So then some people came across and said, well, we can be smarter because some people have a big head, a small head, etc. So they devised the BEAM F3 cluster. Very important for all the EEG people. The BEAM F3 is not the same as F3. It was inspired on F3, but there's a bug in the software, which means that you always end up a bit more lateral and anterior. So it's slightly different from the fMRI targets, but the good news is they validated it against the anatomical dorsolateral prefrontal target, and it's very closely matching that. So for TMS, I would really strongly suggest to not rely on the EEG coordinate, but on the BEAM method, which is also a much easier method to measure it out and apply on the individual level. But if we then look at this as this target, this is based on the Mike Fox target, we see that the response remission rates are pretty similar. And last week, this new study was published where they really wanted to test this in a head-to-head comparison, randomizing patients to the 5.5 centimeter rule or the BEAM, and there was no difference at all in outcomes. So we have this large blob of prefrontal cortex, which we can target with 2 different heuristics, and we get quite similar response and remission rates. And my thinking is, well, there must be something on the individual level that we could use to optimize the treatment further. Many people then say, well, use MRI navigation, let's make it a bit more expensive and fancy, but this study actually compared in a randomized fashion MRI neuronavigation to the BEAM method, and there was no difference at all. And so there's no need, at least for depression treatment, to rely on the structural MRI. So it is not as much the structural anatomy that we're interested in, but there's probably something different going on. So last week or a couple of weeks ago, we published this review article on biological psychiatry, where we made a review of all biomarkers that have been investigated in brain stimulation. So we mainly focused here on what are robust and replicable biomarkers, because especially in machine learning AI, there's many studies that all claim, oh, we have 100% accuracy, we have 80% accuracy, all often done without any out-of-sample validation and probably things that will not be able to be replicated. So the question we asked is, review the whole literature, look at all MRI and EEG biomarkers that have been investigated, and we required studies to have a minimum sample size of 88 or larger, was based on a power calculation, and or it should be replicated by an independent group. Because replication is really key. We have some failures ourselves as well to replicate things. And so it's really important because you want to get it to a patient. And if you want to get it to a patient, replication is really the key. So when we then zoom in on the fMRI biomarkers, I'll show you the EEG biomarkers tomorrow, then one of them is the DLPFC to subgenual ACC fMRI coupling. So here we're looking at anti-correlation. I think Dirk has explained it in a lot of detail already. So if there's an anti-correlation to the area that you're stimulating with the subgenual, then people should be more likely to respond. And that's based on Mike Fox's work together with Alvaro Pasqualeone. This has been published in 2012. And I think this is the most influential finding so far, and I think this is accepted by most people. Very simply put, you're trying to find the highway to the subgenual anterior cingulate, and if that's where you're stimulating, you're more likely to specifically target the depression network and thereby get an antidepressant effect. So we found this very fascinating for a long time, and we're reasoning like, well, how can we use this in clinical practice? And I'm not a big fan of fMRI, so you get it. We wanted to look at EEG and how we could do it. Also based on the work by Diego Pizzagalli, who has been doing a lot of studies on the subgenual ACC and treatment response, both for MRI, but he's also used Loretta successfully for it. So based on that, we thought, well, maybe Loretta connectivity must be the answer. So we first started with the large iSpot-D trial, which is 1,000 patients that were treated with antidepressants. We used the exact coordinates that they published for MRI literature as well, and we made regions of interest for the right and the left dorsolateral prefrontal cortex, the dorsomedial prefrontal cortex, and the subgenual. And we were mainly interested in looking at the connectivity with the subgenual anterior cingulate cortex and see if it somehow was associated with treatment response. Well, long story short, we could find anything. And we find huge sex differences, and this will be the kind of overall theme for tomorrow as well. Any study that looks at biomarkers but has not separately looked for females and males is probably flawed. And we see that for every biomarker, it's completely different for males or for females. And some biomarkers are only effective in males, and some are only effective in females. And so this also attests to that there's huge baseline differences between males and females. We did not find any real convincing evidence that it was mediating clinical response. So yeah, basically we left this path. So that's as far as the EEG in this presentation will go. So we were then searching further, and we still were thinking like, well, what other technique can we use to look at this? So we came across this paper, and I think if you look at the title, you think like, well, what's interesting about that paper? The paper was titled Localization for Penile Erection in the Medial Frontal Lobe. So they were conducting electrical stimulation in the macaque monkey of all these different structures to see where they could elicit penile erection. However, in a small note, they found that when they stimulated specific areas in the subgenual anterior cingulate, they would see cardiac changes, that heart rate would decelerate with 10 to 60%. And so heart rate would drop as a result of direct electrical stimulation here. So we thought that's interesting. So if you don't need the EEG, but you just use an EKG, that would even be more clinically relevant. So that's how we indeed proposed the frontal vagal pathway to be the pathway that is involved with vagal regulation. We did a very extensive review and reviewed all the anatomical connections that are comprising the frontal vagal pathway. And you will see that there's a lot of overlap with the frontal vagal pathway and the depression network. The subgenual anterior cingulate is in there, the dorsolateral prefrontal cortex, the amygdala, and the vagal nerve. So there's really like a top-down regulation on top of it. If you're interested, there's an extensive review by the one you can see on top there, and especially in the supplement you can find all the anatomical connections and how we've derived that. Also, it's very interesting to note that we know that people with depression have cardiac differences. They have a higher heart rate, they have a lower heart rate variability. But we also know that if people undergo or get a heart attack, for example, or have cardiac issues, they have a bigger likelihood of developing a depression. So there's a lot of crosstalk between the cardiac and the frontal vagal pathway and the risk for depression. So then we started out testing this, and as always, I'm the first guinea pig in our clinic if we want to try something. So here you can see me. I hope you can hear the sound. And here we target F4. So based on the EEG coordinate, you will see my heart rate there, 74. Then it will drop to 73, 72, 71, 70, 69, 68. Stimulation is over, and it will bounce back again. And we thought, that's interesting. So let's now move 2 centimeters more to the back. So now we target FC4, heart rate 80, 81, 82, 83, 84. If anything, it increases. And for those of you who have experienced it, TMS is not a very relaxing thing if you apply 10 hertz. It's not very painful, but I mean, if anything, you would expect your heart rate to go up as a kind of orienting response, or at least it should accelerate. So the finding of very specifically getting a heart rate deceleration, I think is a very specific thing that we've seen here. Of course, this is not rocket science, so we did a first study. This was the first study that we published, which we call a 1.0. We used the old-fashioned 10 hertz TMS with an intertrain interval of 25 seconds. It's an important detail. And here we mainly focused at, we looked at the EKG. We can then see the TMS pulses that are being applied. The EKG is then resolved to an RR interval plot. So we calculate the time between every peak, and that's what's depicted in this figure. And hereby you can see the heart rate across time, and you can nicely see the respiratory sinus arrhythmia running through this as well, which we found a bit problematic at that point in time. So you can then see when you stimulate for a brief period, there's an acceleration here, then nothing happens, and when we target F4, you can really see that even through the respiratory sinus arrhythmia, that the heart rate is really decreasing. And these are RR intervals, so a lengthening means that your heart rate goes down. When we apply this to the whole group, we find no evidence of heart rate deceleration for PZ, which was a control site, not for C3 and C4 either. And we saw the biggest impact for F3 and F4. Those are overlying the prefrontal cortex, and a slightly reduced effect for FC3 and FC4, which would correspond roughly to the 5 centimeter rule. So in that sense, it confirms pretty much what we were expecting. So with this older method, as I alluded to, it's correlational, it works, it's replicated independently by several people, but we didn't find it to be strong enough, so we really wanted to move a bit further. So just to orient you to it, these are all the studies that have been replicating it. It's an independent replication from Sydney, from Paul Fitzgerald's group. This is an independent replication using intermittent theta burst stimulation, where we could also demonstrate that actually blood pressure dropped and heart rate variability would increase as well. So it's also not just a statistical artifact on the EKG. In a separate parameter being blood pressure, we could also see that blood pressure during stimulation was significantly reduced as well. So this is a lot of validation studies, and I think what's interesting in this replication study that we've done ourselves, we've also extended the number of locations that we were stimulating. Let's see, how am I doing with time? And the beauty here is that both in healthy controls as well as patients, we see heart rate acceleration for the sites in red. And specifically, we replicated that FC4 and F4 were showing a heart rate deceleration. So in a data-driven way, we now confirm that the two sites that we talked about, the 5 centimeter cluster and the beam F4 cluster, those are indeed, in hindsight, specifically the ones that are specifically tapping into the frontal vagal pathway, which also matches with the fMRI results.
What's the depth of the focus of the stimulation in this case? Are you targeting the gyral crowns or deeper
penetration depth is about 1 to 2 centimeters.
Okay, so that's like the gyro crown. Slightly. Okay.
So you can't target the subgenual directly, unfortunately, because it's too deep inside the brain. Yeah. And so I think the nice thing, it confirmed in a data-driven way that how they came up with the heuristics, which was pretty much like that, the 5 centimeter rule. That's actually, I mean, it was a big accident, or how do you say it, serendipity, which ended up working very well for most people. And it also explains why, on the group level again, those sites are quite effective as well. So what we then started looking at, there was an update in the FDA-approved protocols, which allowed us to shorten the intertrain interval. With an intertrain interval of 25 seconds, you can push down your heart rate, and 25 seconds would be enough for it to normalize again, but then your respiratory sinus arrhythmia will take over. So we could now safely reduce the intertrain interval to about 11 seconds. So that means we have 5 seconds on, 11 seconds off. And that's enough to really keep the heart rate at a low level, let it recoup, and then the next train of stimulation will push it down again. And therefore, with the new method, which is called heart-brain coupling, we're not interested in the heart rate deceleration, but we're interested in the rhythm that we're entraining with the TMS. And so it's a completely different way, and this is causal. It's so causal, I still want to do this experiment, that I dare to apply different stimulations here, pick it up on my heart rate, and be able to decode a Morse code from my brain based on my EKG. That's how reliable it is. So it's really a causal manipulation as long as you're targeting the right area. So if this indeed pans out, and if what I'm saying here is true, then we could conceptualize that when we apply 10 Hz stimulation for 5 seconds, we then have an intertrain interval of 11 seconds of no stimulation, and then you would predict that there will be a spectral component of 0.0625 Hz. Because the cycle time is 16 seconds, and 1 divided by 16 should be this specific component. However, if you would do intermittent theta burst stimulation, which is 2 seconds on, 8 seconds off, here we see a cycle time of 10 seconds, then you would predict that the spectral component of your heart rate would be 0.1 Hz. So 2 very specific predictions we could make. So the first thing we did is we asked some people, like, well, do you have some data for us that we can have a look at? So we asked the Canadian group with a card bind, and they had collected EKG during intermittent theta burst stimulation. We contacted Nolan Williams from Stanford, who did the SAINT trial, and he also collected heart rate during the SAINT trial. And those were placebo-controlled studies. And we asked them, like, well, give me your EKG, and we will analyze it in a blinded fashion. I don't want to know anything. And we will make a prediction who is receiving sham and who is receiving real stimulation. Then we shared it with them, and they confirmed, they then said, well, this is real and this is sham. So we were accurate in 83% in the card bind and 90% successful in the SAINT trial. So I think that was quite amazing, really in a solid blinded fashion, and that we could indeed tell whether it was real or whether it was sham. And this is what it looked like. Here you can see time, and you see the heart rate, and you can see indeed a perfect, this is like one stimulation train, so every gray bar will indicate it. So you then see, if you do a time resolution plot, a frequency plot with either a high time resolution, you can tell even the individual stimulation trains simply by looking at heart rate. But when you take a high frequency resolution, you can see confirmed that there's indeed a specific discharge at 0.1 Hz. When we look at sham, you don't see anything like that. So it's really, I mean, I think you can tell from the raw RR interval that there's really something different going on with the TMS stimulation. So then we also devised a different way of applying the 10 Hz stimulation, because in theory, it's not only about finding the right location to stimulate, but also we still rely on the motor threshold. So the thump is a crucial thing in TMS, and we want to design out the thump. So basically now TMS is applied, and you find the minimum intensity that you get a thumb twitch, and that's what you extrapolate to the prefrontal cortex. But we know that the prefrontal cortex has a different excitability threshold than your motor system. And so that's what we tried here. We still, for safety reasons, need to maximize it to 120% of the motor threshold. But now we start the intensity 28 machine output points below the motor threshold. And then what we do is we apply one train of stimulation, and every next train we ramp up the stimulation with 2 points until we have reached the 120% of the motor threshold. And so now we can also determine a dose-response effect and see at what specific intensity does your prefrontal cortex start switching on. So this is what it looks like, and this is 2 examples again to show you and orient you. And I think now the beauty is that even within subject, within location, you can see from low intensity to high intensity, you can immediately see the difference. I mean, I think Jay will probably see some beta that synchronizes into alpha or theta in this, which is a way to look at it as well. And you see that there's the respiratory sinus arrhythmia in the beginning, and later on it starts synchronizing into this 0.0625 hertz. So exactly the predicted frequency that we predicted where it would start switching on. Secondly, what you see is this is what you would normally expect, a nice dose-response effect that increases when the dose is increased. But we also find people that show a very completely different dose-response effect, where maybe treating them with a higher intensity could be less beneficial for them, because they're actually switching on much below the motor threshold already. And so I think there's a lot of individual differences that we see here as well. And this is also to show you the contrast that indeed when you do the cycle time of 16 seconds with 10 hertz or the cycle time with ITBS, that indeed the spectral component is shifted and is only directed based on the cycle time that you're presenting the stimulation with. So this is the replication trial that we are currently finalizing. So we now replicated this in 40 people. One of the previous reviewers was very critical and almost rejected the pilot study we published because he thought it was all mediated by pain. Whereas we said it's completely not true. In the SAINT trial, for example, that we unblinded effectively, they applied lidocaine to the stimulation site, so there was no pain difference there. So we now did a very extensive analysis to rule out that the heart rate deceleration is just caused by pain. That could hypothetically be, and that would be completely different from being a specific frontal vagal activation, because then it would be just a side effect that's causing the heart rate decrease. So we've ruled that out effectively. We now established a frontal excitability threshold, and here you can nicely see for every individual their motor threshold and their frontal excitability threshold. And we can now determine from when the heart-brain coupling starts popping up, meaning like, okay, that's your prefrontal thumb movement, if you will. And the blue line indicates if they would be identical, it would follow the blue line. And you see it is not. It's statistically significantly different, and the difference between the frontal threshold and the motor threshold is about 9.8 machine output points. That will effectively translate into a difference of 20% when you relate it to the motor threshold, because often your motor threshold is around 50. So you also see it's not linear in a sense, that the lower your motor threshold is, the bigger the difference in your frontal threshold. So really an important finding that we need to consider an individualized frontal excitability threshold if you're treating with the prefrontal cortex. And we also see individualized dose-response effects. So indeed some people will show an increasing heart-brain coupling when you increase the dose. But for some people it will appear very early, and for some people it will appear much later on. And so there's also quite strong differences there. Why it's really important is this case. We had one case in the study where one of the people that was stimulated actually fainted, a syncope. And a syncope is a very well-known side effect of TMS. But most often people say, well, people are just excited. I mean, I've seen it with EEG as well, that some people fainted when you get the needle for the gel. So there can be anxiety or stress-related syncopes as well. But what we've shown here, because we had the EKG connected, is that this is a no syncope case. Here we see dose is increasing from no stimulation to here. And here we see at a higher stimulation intensity, we see the heart-brain coupling occurring. But with this specific individual, we saw that heart-brain coupling was already there at the second intensity. So at a very low intensity, which was roughly 75% of the motor threshold. So that was very low. And we can also see, if you look at the heart rate was 80 in the beginning, and you can see here it dropped to below 60. So 20 BPM of a decrease in heart rate. Well, I think it's not rocket science to conclude that you might be fainting as a specific effect of the TMS that we applied. And so I think also in order to prevent side effects like this, it will be very crucial to really establish a reliable frontal excitability threshold. So this is a demo, so I'm really proud. This is also how we prefer to do our research. We've made an iPhone app to make this accessible to everyone. It's called the Heart-Brain Connect iPhone app. It uses a polar H10, and you can simply use a protocol that we have on our website. It will then assess your heart rate on 4 different locations that you can choose yourself, either the beam, and it will provide you the output in real time. So you can now apply TMS, get an iPhone app with a polar H10, and based on that you can decide what target to trade. And the very important thing is, you could then say, well, isn't that very experimental? We haven't proven anything. Well, we know for sure that if you target this one or this side, there's no difference in effectiveness. We've seen that. And so this is what we call stratification. I'll talk a lot about it tomorrow as well. If I flip a coin and assign a patient to either this or that side, there's nothing ethically wrong about it. So if I exchange the flipping of a coin by looking at heart rate, I'm not doing any harm. If anything, I would hope at least that the outcomes will be better. And that's something that we're currently testing, of course, but you need a large sample in order to realize that. So at this point in time, we propose at least that this heart-brain coupling can be a great technique to stratify people between 2 evidence-based targets for the treatment of depression. This is the output you will get in your iPhone app of 3 different individuals, and it will also highlight which location is then showing the strongest heart-brain coupling. So it will highlight it for you, but you can also, like in this case, you see that there's actually 3 targets that are all showing quite significant heart-brain coupling, whereas for this subject, there's quite specific heart-brain coupling only at this location. Okay, so now a very important and a very exciting finding. This is not published yet. So remember that we started, the inspiration was Mike Fox's work, that you're identifying an anti-correlated site that's anti-correlated to the subgenuine. And I have not shown evidence yet that that's really what we're doing. So when we presented this data, Mike Fox and Sean Siddiqui were quite interested, and they said, well, why don't we test it? So actually, one of our PhDs went to Harvard in order for them to test this out, and that's quite exciting. So what we've done now is we have taken in 15 people their fMRI scan. Mike Fox and Sean Siddiqui analyzed it on an individual in the way they normally do it, and they would then identify for every individual a positively correlated, an anti-correlated, and non-correlated sites. And we would then, under neuronavigation, using neuronavigated TMS, stimulate those different locations and at the same time measure heart-brain coupling to indeed investigate, is this mediated via the subgenual ACC? So this is what all the stimulation targets look like. You can see we basically covered the whole prefrontal cortex. Every dot is a different individual, of course, but you can see it's not just one location that's the same for everyone. So that nicely confirms that the anti-correlated sites can be quite different. We applied the same protocol. We used our iPhone app as well. And guess what the outcome was? The outcome was, if we only looked at the iPhone app and we said, okay, we predict that this will be an anti-correlated site, the accuracy was 12 out of 14. So we were right in 86% of the cases. So can you use heart-brain coupling to identify an anti-correlated site? The answer is yes. So I think we've effectively designed out the fMRI from TMS. We also we looked at the posterior cortex, so we did it primarily prefrontal, because that's what we're interested in. But because there's also very strong anti-correlation in the posterior cortex and there's fewer muscle tissue, it could be better tolerated if you apply it to the parietal cortex. Unfortunately, we could not, it was chance level prediction when we applied it to the parietal cortex. And so there's some heart-brain coupling that you will see in the parietal cortex, but it's not mediated via the subgenual anterior cingulate at least. So interestingly, there's some post-hoc work when we indeed looked at the difference between negative or anti-correlated sites versus positive or neutral correlated sites. We indeed can confirm that there's more significantly higher heart-brain coupling in those sites. What's even more interesting, and we don't have an answer for this one yet, is if we look at the fMRI connectivity strength, and we correlate the fMRI connectivity strength with heart-brain coupling, we don't find any correlation for the left hemisphere, but we do find a very strong correlation between both measures for the frontal and the parietal right hemisphere. And I think these are quite strong correlations, and that indeed the strength that the fMRI determines is one-on-one related to heart-brain coupling, which I think is very exciting. But it also suggests some form of asymmetry. It might be related to the fact that, for example, if people do vagal nerve stimulation, that's only applied to the left, because according to the FDA, you get more cardiac side effects if you target the right vagal nerve. So it could well be that this indeed confirms that there's a somewhat stronger heart-brain coupling specifically for the right prefrontal cortex relative to the left prefrontal cortex. But of course, we need to investigate it in more detail. But I think it's a nice confirmation that the strength of our association is correlated as well. So we have now the iPhone app. We have a controlled replication. The thing that's still ongoing at this point in time, we have 3 large clinics where we are now using this prospectively. We have now already assessed about 200 patients that were treated with standard care, treatment as usual. And with all those 3 clinics, we shifted them to heart-brain coupling inspired target selection. So we're selecting the site based on heart-brain coupling, based on the rationale I just provided. Hopefully by the end of the year, we'll have like 200 new patients treated prospectively, and we hope that we'll see a bump in remission rates. We don't know. It takes large samples to really do that work.
You guys are using 10 hertz on the right to see the coupling. Are you then treating with 1 hertz?
Yeah, so indeed, important, good question. So indeed, we are for the heart-brain coupling, we need the 10 hertz frequency or ITBS frequency because that's what shows the specific heart-brain coupling. When we identify a site on the right prefrontal cortex, subsequent treatment will be with 1 hertz. That's correct. Again, hypothetically, I would think that 10 hertz on the right would be equally effective, but it's too experimental and it doesn't meet the requirements by the FDA at this point in time to try it out in clinical practice.
When you then apply the 1 hertz on the right, is there an increase in heart rate because you're inhibiting the parasympathetic system?
Yeah, good question. I think the jury is not out on it. If you look at the study from Marina Kaur, that's the Australian replication, they did 1 hertz as well, and they tended to see a slight increase in heart rate. Jonathan Downer has done a study as well that looked at the longer term where he saw a kind of a heart rate decrease. So I don't think, and we've looked at ourselves as well, I think the 1 hertz is too unspecific. We've also looked at maybe we should apply using closed loop stimulation the single pulse in a specific timing relative to the R peak. We've tried to look at it, but we didn't find it convincingly at this point in time.
And one more question related to the increased coupling on the right versus the coupling on the left PFCs. Is there a greater modulation of heart rate when you stimulate the right versus the left?
I don't think so. I need to check. It's a good question. But I don't recall it being different on the right and the left, but we can check. It's a good one. We'll add it to the analysis of the ongoing paper. Yeah.
There is 1 or 2 studies that actually show that in the vagal nerve you also got sympathetic fibers, not only parasympathetic fibers. So this could explain, maybe depending on the stimulation design, that you might more selectively modulate sympathetic fibers that are present. It's a small bundle, but they do exist inside the vagal nerve. So the vagal nerve is not only parasympathetic.
I wasn't aware of that. Interesting. Yeah. Okay. Could well be. Jay?
You've established that doing psychotherapy and TMS together in the same session is more efficacious. In the U.S., the insurance companies will not pay for them at the same day.
I know.
We're working on that, Jay.
Yeah, but it has to be worked on because it's stupid.
I know. No, no, it's a good one. And the funny thing is, I mean, of course, critical people will challenge and say, well, but you have not done a randomized study where you randomize to with and without psychotherapy. I always tell people, well, if I'm selling a very expensive device, like a brain sway or whatever, or another very expensive thing to make this claim, yes, then I need that data. I'm just saying, like, well, just have a chat with your patient, roughly put. The cost-benefit really outweighs it. And I believe there's a good reason for it anyway to also prevent relapse and other things. So I think it's a very sensible thing to do. But also, I mean, even in the Netherlands, where it is allowed and where even the insurance company in the beginning was enforcing it, most of the hospitals are not doing it because they have a technician. The technician does a TMS, and they cannot get it organized to do it. So the way they've done it right now is they say, okay, we do TMS monotherapy, and the patient will get one time per week, they will get a group CBT session to go around it. So even in the Netherlands, where it's recommended by the insurance company, people are simply not doing it. So yeah, it's still too much seen as just a tech fix, whereas I think we should really be integrating treatments much more, and not only aspects of sleep, but also psychotherapy and these techniques. Yeah.
Really interesting process. Really interesting process. A lot of this is new to me. So would it be correct to say that here, by doing this unique type of stimulation where you're looking at the entrainment between the heart and brain, one of the kind of main benefits is, apart from just stimulating parts of the brain that seem to be associated a lot with depression and improvement there, we're recruiting benefits of the vagal, also kind of parasympathetic response, and kind of putting those together. Would that be kind of in line with how you are thinking of the importance of this synergy between,
yeah. So if I take the question correct, would it also be expected that you would see not only treatment effects for depression, but also effects on blood pressure, heart rate variability? We have looked at it in the one study where we've collected the data. So there we also did a statistical analysis where we looked across sessions, and we could not find, we would see that the heart rate changes would be there every session, but it was not true that the baseline heart rate changed, unfortunately. I mean, otherwise it could be an interesting treatment for high blood pressure and stuff like that. But so far, again, I'm not ruling it out because it was a limited sample. That could be a sample size issue. But so far, we're not seeing convincing evidence that we see long-term cardiovascular changes as a result of this treatment. No.
Thank you.
So, sorry folks, I just want to be mindful of the live stream. Maybe we could let you continue speaking towards the end and then get back into using the microphone, or do you want to continue in this way and people can go to the mic?
I think on one hand it's more interactive. What I can do is to try to repeat the question so that they get it online as well. Yeah. Yeah?
So what happens if we deliver the bilateral stimulation? Does it linearly increase the effect twice?
On heart rate, or so the question is if you apply bilateral stimulation, if it would increase the effects, but are you referring then to the antidepressant effect or the cardiac effect, or both?
In any sense.
Yeah, I mean, historically we've been targeting, we always start out with either the left or the right. So we apply TMS there, and often when we see that patients do not respond, we often add the contralateral DLPFC to it. We've done that historically for a long time. Quite recent evidence from large registries are suggesting that's actually a less effective approach. So we don't see a doubling. Sometimes we got the impression you might rescue a patient from adding the contralateral hemisphere to it. There have been bilateral studies as well that did 1 Hz on the right, 10 Hz on the left. Overall, I don't think there's convincing evidence that you really get a huge increase in outcome. What we currently do consider is a completely different target. It's an experimental target. It was just accepted for publication. We're more targeting the orbitofrontal cortex in patients that do not respond. We don't see the specific heart rate changes when you target the OFC. It's also a completely different clinical response. But we do see that patients that are completely unresponsive to DLPFC TMS, that about 30% can still gain remission when we switch them to orbitofrontal stimulation. And there's now 3 open label studies that confirm it. So again, it's not evidence-based yet, but I think knowing what the alternative is in this very treatment-resistant population, I think it's really something that can be considered for those patients. Yeah.
So I have a couple of questions. One, the psychotherapy that you do, what exactly are you using? Because there are different types of psychotherapy. So, you know, the question is whether there's an effect based on the psychotherapy type that you're doing.
Yeah. So the question is about what type of psychotherapy we're doing. I get this question very often, and again, I'm a biological psychologist, not very well versed in psychotherapy, but what they've told me is it's eclectic. It means that it's different for every patient, because these are highly treatment-resistant patients, and you cannot start repeating something that they've already tried. And so that's a personalized thing. Often it will contain many elements of CBT, cognitive behavior therapy. So that's what the main foundation is. But of course, sometimes they can add schema therapy to it, sometimes even EMDR. And they're adding different, that's a really personalized aspect there.
Okay. And the second question is, so this is mostly figure of 8 that you're using. What's your experience with respect to deep brain stimulation, like brainwave stuff?
Yeah, in one of the earlier studies, so the question is, this is mainly based on figure 8 TMS, that's a standard figure 8 coil. So what about brain sway deep TMS? And we have investigated it. We had a brain sway device in our office for some time. So in the first replication study that we did, we applied both figure 8 TMS to different locations, and we also did a single shot of brain sway TMS, because it's not as much deeper stimulation, but I think a wider area that they are stimulating. And we would then hypothesize that you're more likely to at once hit the right frontal vagal pathway with deep TMS. But unfortunately, that didn't pan out. It was quite similar. And so the likelihood of hitting the frontal vagal pathway was pretty much identical for brain sway relative to targeting F4, for example. Yeah. So we didn't see a real qualitative difference there. The only downside, and Abraham Zangen pointed us to it, we only went to 110% of the motor threshold. And according to them, 120% could make a difference. So we cannot exclude that at this point in time.
So you showed one previous study about the stimulating the medial frontal lobe and the monkey penile erection, right?
Mm-hmm.
Does that also, or similar phenomenon happens in the case of the humans? For example, when you stimulate certain parts of the brain, then that affects the gustatory function, for example. So that's entirely possible, right? Because the heart is a big source of the electric activities, and it's easy and established method available to measure its activity. Then you notice it. But there may be another effect which is not measured but happening in, I don't know what's the major, there's a controlling system there.
Yeah.
But like, for example, the electrogastrogram, there may be those correlations, right?
Yeah.
What do you think of the potential, like, hopefully that effect is neutral for now, but there could be a positive and negative the influence on the other organs, right? What do you think?
Very good question. The question is, would there also be other effects? Because the vagal nerve not only innervates the heart, but also the gut and basically a lot of organs in the body. And I think it's an excellent question. I mean, indeed, regarding the penile erection, where we started with, that's not something, at least, that I heard, that occurs quite often. I don't think it's systematically asked for patients as well. So that part, I don't think there will be something there. But I think it's a very valid point. I mean, it also ties into the heart-brain, but also people talk about the heart, or the gut-brain axis, and there's a lot to do there as well. A lot of the communication via the vagal nerve is also coming from the gut, especially even some, it is talked about that some of the infections from the gut can transfer via the vagal nerve into the brain, related to some forms of Parkinson's and other diseases. So I think there's a lot of exciting new insights there, because it really extends our view on the brain to involve the whole body, if you will. And indeed, I mean, electrogastrogram is definitely something on the list that we want to start looking at, to also see, I mean, what's going on there. It is known already for the default mode network that if you look at the slow oscillations from the gut, that somehow they are associated to the fluctuations you see in a default mode network. And indeed, will it be better or worse? We don't know. Again, we know from the long history of TMS that from the side effect profile, it's a very benign treatment. The only side effect is like muscle pain or headache related to the stimulation. Indeed, the epileptic seizure, which is like very, very small likelihood. But gastrointestinal issues have not been systematically observed as far as I know. So if anything, I would maybe even think that there might be beneficial effects on the heart-brain-gut axis, if you will. But that remains still to be investigated.
I'm interested in the association between stimulating the anterior cingulate, which has frontoamygdala associations, and the stress coping response, the fight, flight, or freeze response that you may be seeing replicated in the heart rate data. So the fight response is increase in sympathetic tone with an increase in heart rate. The flight response is bradycardia, slowing of the heart rate. And the freeze response also is a more severe bradycardia, but it's not a passive condition. It's more like the heart rate is slowing enough in preparation to make a plan. So, you know, the anterior cingulate's the head of the salience network, and it participates in threat detection due to the associations with the amygdala. I'm wondering if you could comment on the possibility that this connection between stimulating the anterior cingulate and seeing these different patterns in different individuals, because it seems to be an individualized response, might be based on the person's vagal tone. And it could even be based on the person's history of trauma, given the likelihood of whether they're going to go into fight, flight, or freeze mode.
Yeah. So the question was related to the fight, flight, and freeze response and how that could be related to these effects. I think a very good question. I think we've in the review that we've published, we focused on this quite a bit because indeed, how do we know that it's specifically the vagal nerve that we're activating? I think there's several lines of evidence suggesting it. On one hand, the fact that we saw it on blood pressure as well, which implicates a wider parasympathetic response. We ruled out very extensively the effect of pain, because indeed pain could result in a kind of freeze response and might also show a kind of slowing of heart rate. And we could really rule out that it was mediated via just the perception of the pain. And also an important aspect is that the vagal nerve is a myelinated nerve, and the accelerated nerve, which is the sympathetic nerve, is an unmyelinated nerve. And so that would also mean you've seen the swiftness of the heart-brain coupling, that it's really like an immediate thing that happens during stimulation on a millisecond time scale. And if it would be mediated via the sympathetic nervous system, it would be a slower effect, not as immediate as we see it. So I think there's several lines of evidence that are suggesting it, and also some animal research where they've been able to manipulate in more detail are suggestive of that as well. Again, there's more questions we have at this point in time based on this method than what it can answer, but yeah, I think a lot of potential future research can focus on those aspects.
Yeah, I'm really intrigued by the association. I think Stephen Porges was the person who discovered the non-myelinated connections to the heart.
Okay.
Specifically that are involved in the freeze response. But I don't want to go into that in detail, but I'm really intrigued by the threat detection system and the heart rate data combined. I think it has something to do with the individual's resting state, vagal tone, perhaps, and their trauma history.
Yeah. Good things to look at further. All right.
This is just because I'm a newbie, but why do you like TMS over TDCS?
Well, for depression at least, the evidence is much strongest. There are several reviews that have reviewed the whole literature. So TMS, especially in treatment-resistant depression, has the highest level of evidence. If you really rely on the largest studies currently published by André Brunoni, he has published 2 large trials, one non-inferiority trial on TDCS relative to escitalopram, if I'm correct. And there was about 300 people. So that's really data that you can start generalizing. And there the effect of TDCS was actually slightly lower than the effects of antidepressant medication. And the effect size, I think, was 0.2, 0.3, really on the low side. And then with TMS, you simply get much stronger clinical benefit. I think in another trial he combined sertraline with TDCS, where the combined effect was slightly better. But there it's really hard to tease out if it's the medication, if it's the TDCS, or actually the combination that's augmenting each other. So for TDSS, I think at this point in time, at least in depression, the current evidence is too limited in my view to really use it there. That's not to say that maybe for maintenance treatment, I think that could be a very interesting thing to explore, if TDCS could be a right way for maintenance treatment. Another idea we had for a long time is that because TDCS is not stimulating the brain, but it's simply manipulating the excitability threshold and increasing the likelihood of firing, that maybe TDCS should be combined with something different like psychotherapy. There's been a large trial that was running in Munich in Frank Padberg's lab, and unfortunately that was negative. So they did not find any enhanced benefit of combining psychotherapy with TDCS. It's quite a funny study. I mean, they did group psychotherapy, so people would all wear the TDCS headset. Half of them would be sham, half of them would be real, and they would then get psychotherapy in the session. I think there was also about 100 or more patients. So those are really the effects, the large studies that you need in order to judge if it's clinically beneficial. Yeah.
The related question. So in theory, and I think there is also one application, at least by Don Tucker, but if you have a dense array like electric stimulation electrode on the scalp, and makes the current field to make a narrow focus inside the brain. So by taking advantage of this reciprocity principle, so if there is one source of the current inside the brain, then that spreads and recorded on the surface of the electrode, right? So if you give the same stimulation obtained by that forward model result, then you can basically get the same source of the stimulation. So this is a reciprocity principle. So if you use that, then you can stimulate the very narrow area of the brain. I mean, there is of course a limitation due to the volume conduction and blurring, but maybe something like a few centimeters scale. So could that be a future alternative of the TMS, or because so that it's going to be, the system will be much cheaper, right? But do you think there is such a possibility?
Why would it be cheaper?
Well, because in a TMS you have to have a really big amplifier and this big coil, because that should put up with this
So you're more alluding to subthreshold stimulation, that if you have stimulation on multiple locations, that it could sum up, or?
Right. Probably what we need to stimulate the brain is only a few milliamperes in the end, right? So instead of using this magnetic field-based approach, if we can deliver the current, but with a very spatially narrow targeting.
Yeah, so you're talking about TDCS, but then high definition TDCS.
Exactly.
Yeah.
Exactly.
Yeah, but I think there's a lot of work. I mean, there's of course the Soterics approach, where they use multiple electrodes, and they call it high definition TDCS. There's been a lot of work. I think indeed, I mean, what's the system called again? The dense net, Don Tucker has invented it. EGI, yeah. So EGI is now part of MaxTim, and I think they have ongoing approaches to indeed do more specific modeling and target deeper areas. And I think you alluded to that work as well with the difference waves that they're doing. So I think there's many efforts going on, but at this point in time, you need studies, and you need large enough studies to see if it's better or if it's working at all, and that's currently is not there yet. No.
But what's the specialist take? So is there a very high expectation in the field, or are they rather dismissive?
I think the work that Dirk alluded to, I think is very promising. I mean, there's many people that are trying to replicate it right now using the difference wave to really target much deeper areas. I think that's very promising. I think there's a lot of research effort on that right now. So I think that's definitely a really promising approach. And of course also other types of neuromodulation. I mean, TFUS, transcranial focused ultrasound, is being developed in a similar fashion as well, where you can do neuromodulation. So it's hip and happening, the whole neuromodulation field. There's so much development going on, so it's exciting times. Yeah.
In your studies, did you only do monopolar depression, or was it bipolar depression as well? Because it's a very different animal from the perspective of the PFC areas affected in bipolar depression.
Yeah. So the question is what type of depression we've seen and treated so far. I think the samples we've seen is mostly unipolar depression, although there will also have been bipolar depression. Some data suggesting that bipolar depression might sometimes even respond better, but at least there's no indication that the response rate would be lower as long as it's focused on mood, of course, not on the manic aspect. The only subtype that is pretty unresponsive to TMS is psychotic depression. And psychotic depression, which also is a positive predictor for ECT response, for them it's quite hard to get them into remission. That's the overall what we see. Yeah. Yeah.
Yeah, I was curious about the sham groups and the placebo-controlled groups. If the subjective experience of receiving TMS is let's say, shocking, and with TDCMS, how do you deal with that in your sham groups?
Yeah. So the question is indeed about the sham groups and what type of sham control. Yeah, I think the perfect sham doesn't exist, and I think that's pretty much everywhere. I think we've seen that in TMS. The sensation will be different for some people, and there's various approaches to it. I mean, there's coils that block the stimulation but do have the superficial sensation of it. Nolan Williams, what he did in his trial is apply lidocaine in order to mask it out. So there's different ways of dealing with it. In the really early days, they used a coil which they simply flipped 45 degrees in order to only have the superficial stimulation but not the depth. But I think there's, at this point in time, there's been so many controls, many different types of control groups that were all positive to find an effect on depression, that I think that we can be quite certain about it. But indeed, I mean, there's a lot of discussion about what is the perfect control. They also use sometimes electrical stimulation along with it to mask the effect. So yeah, there's various ways they've been able to do it. In the studies that we evaluated, there were two different designs. So one of them was masking it with the lidocaine, and I think in the other study they used different locations. So there was an active other location there as well. Yeah.
So I just wonder, is there kind of known mechanism whereby the heart-brain connection is instrumental in, I guess there's like a parasympathetic, maybe that's the one, but is kind of uniting, I mean, you mentioned something like Klimish's view of also like gastric waves, the heart, there's obviously a lot of interconnection, but is that kind of bringing them together a supposed antidepressant effect, or thought to be also continual, you know, uniting the heart and brain?
Yeah, and so the question is about the vagal nerve, the parasympathetic system, and how that interconnects. I mean, as far as I know, I think the vagal nerve is actually seen as the branch of the parasympathetic nervous system. So, yeah, also, I mean, for us, it's whether it's truly related to depression or not is beyond the fact. I mean, initially we've seen how we just wanted to get an output of the prefrontal to subgenual ACC anti-correlation to replace that with a more easy-to-use metric. And whether the heart rate and the vagal nerve is or is not specifically implicated in depression, that was more like a side effect, if you will, because the primary interest is the subgenual ACC connection. I think it makes a lot of sense that.
The direct goal is to anti-correlate the subgenual from the dorsolateral?
No, the direct goal is to identify a prefrontal location, which basically, via its anti-correlation, is functionally connected to your subgenual, to target, to transsynaptically target the right network. That's basically the idea.
Where it's anti-correlated?
Yeah, so the anti-correlation implicates that it's functionally connected.
Okay, and you want to re-entrain that connection between the...
That's the question that no one knows yet, how TMS works. We know it does work. That's the working hypothesis, yeah.
Very interesting.
Yeah. So basically it all stands on the idea that the Mayberg BA25 target is essential for the antidepressant effect. Now the problem with that is twofold. One is that if you do a neurosynth meta-analysis of frontal imaging and you look at depression, you don't find it. But you do find it in anxiety. So has there been a study where they looked at whether the patients that do respond would be patients that present with anxious depression, or what they formerly called agitated depression, or at least have comorbid anxiety, versus just depression without an anxiety component to it. And second of all, there have been a couple of studies that put an electrode implanted in BA25 and Mayberg's target, and as long as it's open label studies, the response is good. However, once they go to placebo-controlled studies, there is no benefit. So the question is BA25 the right target to have an antidepressant effect? Because you could also imagine that the vagal nerve stimulation via implants is known to have an antidepressant effect. So are you not just doing vagal nerve stimulation via a complex pathway, that you then have an antidepressant effect by just stimulating the vagal nerve?
Yeah. Yeah, so the question is about the subgenual area 25 and how specific it is. I think a couple of comments. I don't think that it's only the subgenual that we're targeting. I think it's a whole functional network that we're targeting, of which the subgenual is a part. So I don't think it automatically discredits the whole idea. I know of that failed replication from Helen's study. I think she has a quite different view on it as well. It technically was a failed trial, but remember that the neuronetics TMS trial was technically a failed study as well. It didn't meet its primary endpoint. But still, after a lot of discussion, the FDA decided to still approve it. And I think with the subgenual ACC deep brain stimulation study, there's something similar, because the time point was wrongly picked, according to Helen. I think there's a couple of good commentaries online that if you read them, you'll see that in the more subtleties, there is a pretty good signal still for those studies. Whether it's just an anxiolytic effect, I doubt. Yes, as a result of TMS, you will see that on comorbid anxiety, there's quite significant improvements as well. But I doubt if it's just an anxiolytic effect that's mediating the whole effect. But again, we can't rule it out. Also, I think describing depression in terms of, I don't like that to begin with. I think we should get rid of the DSM and those behavioral categorizations to begin with. At least what we see, and maybe also more observational, we do see that patients get better after TMS. And if they relapse, they also come back to the clinic to get retreated, which really tells me that there's something clinically relevant about it, because otherwise they would not come back to get the treatment again. And so I think it is a highly clinically relevant treatment for many people. For the sake of time, I have 2 more slides to finish. Can we then get back to the questions again? Okay, so the current status is that we have done a replication study, and we've collected the retrospective data for 200 patients. By the end of the year, I hope to have 200 prospective patients to see if it is or is not improving the treatment. Again, you have got 2 active treatments, and you need huge sample sizes to find the smallest difference that is improving it. So that's still to be done. And one thing that I haven't touched upon, but it's something we just finished, is we have also looked at, because there's many questions that we can answer now, we have a direct output of the prefrontal cortex. So one of the questions is, what is the difference in pulse shape, pulse width? This is very technical, because most machines have a pulse width of 320, 350 microseconds. Some systems claim to have much shorter pulse width, like Neuronetics and Megan Moore, like 160 microseconds, but doesn't make a difference for treatment. And also, it's a cosine wave, pulse wave, that we're providing with TMS. But what about a square wave? According to some people, with square waves, you can have a much more efficient system that doesn't overheat that much. So we have been quite fortunate to be collaborating with Charlie Stack in Oxford, where they have 2 quite experimental machines. There's only 2 in the world of this one. This is called XTMS, and this is called CTMS, or controllable TMS. So with this machine, several studies have been published already. You can have pulse widths of 30 microseconds Remember that the fastest in the market at this point in time is 160, 60 and 120 microseconds with square waves. So we have also applied this to the brain and looked at the heart-brain coupling and to what degree it was different for these different pulse widths. And indeed, there seems to be some suggestion that really short pulse widths seem to be slightly more better capable of the heart-brain coupling. This is called XTMS, so because this system is limited to square waves, but this system can generate any pulse shape you like. If you draw it on a piece of paper, any pulse shape you like, they can generate it with this machine. It's like this high in the machine, it's like this width, so it's a very interesting design, but it will really allow us to see if we can optimize the pulse parameter stimulation parameters of TMS. So here we are actually comparing all the devices that are out there, because the FDA, in my view, is a bit sleeping every now and then, because they have all different pulse waves, pulse shapes, etc., but they're still considered substantially equivalent. But if you have a pulse width of 160 or 320, that's quite a big margin and quite a big difference. Yes, they will make your thumb move, but doesn't mean that the clinical results will be the same as well. So stay tuned. This is something we just finished the study. We're currently writing it up and looking in more detail what's come out. But also I think it illustrates that many things we can start looking at. Coil angulation. And we know that you can make your thumb move if your coil is angled at a 45 degree. If you stimulate the exact same location at a different angulation, your thumb will not move. So we can investigate similar differences for the prefrontal cortex to really make sure that the whole frontal vagal pathway is activated. So with that, I want to summarize that heart-brain coupling, I think, is robust. We've really replicated it. I think it's really a causal manipulation that we can do. It can be used for site selection to stratify between two evidence-based treatments, either the 5 centimeter rule or the beam. Of course, people might want to go more experimental and start hunting or searching for different sites. I think we still need more research there. Frontal thresholding, I think, is an exciting new application of it as well. And I think we now nicely validated the assumption we had that it's indeed the subgenuine anterior cingulate that's at least a key hub within the whole system. I don't think it explains everything, but at least we can ensure target engagement. It's a very important aspect, that we can engage the target efficiently by looking at heart-brain coupling. And I think it's really causal functional connectivity. So there where the MRI world is always talking about functional connectivity based on some blobs and images, I think there's nothing more causal. If I push a button here and your heart rate changes, and then I'm very sure that there's a functional connection between those two systems. With it, this is just me, but there's a whole group of people that are conducting the study. The heart-brain group is Lauren, Eva, and René. So they've been doing a lot of the work. Eva has done the work in Boston, and Lauren has done the work in Oxford. And so there's really a large group into it, and Hanneke is the smart cookie that has made all the programming and all the code behind it. And with it, I want to thank you for your attention and invite you for further questions.
Thank you very much for your talk. For anybody who's going to go kayaking, there's 9 kayaks waiting across the water on the other side all the way to the end. If you get there, there's a free kayak. You can go paddling for an hour or so. Try to be back here by 2.
Do you have a question? And we have about 2 more minutes before the break, so this will be our last question, and then we'll head to lunch.
So mine is a comment rather than a question. So as Martijn said at the beginning, people love the expensive toys and it gets more attention and more research money, but most of us here are doing neurofeedback. So remember that there was a study done by Brendan Parsons for his PhD at the University of Montreal, and he had looked at the work by Mayberg that these gentlemen have cited extensively, and that was where she implanted electrodes in Brodmann area 25, the subgenual cortex, ACC. And Brendan Parsons, using neural feedback, got the same results as she did in terms of remission from intractable depression. So if you want to try this with neural feedback, look up Brendan's work. Parsons, Parsens, S-O-N-S, Brendan Parsons.
One more quick one.
I couldn't agree with you more regarding DSM-5, but my question is simple. Are there indications for TMS in the treatment of psychosis?
Yeah, there have been a lot of studies in schizophrenia. Initially, it was focused on the positive symptoms like auditory hallucinations. Initially, were positive results, but later on, it could not be replicated. Most current studies are focusing on the negative symptoms, which seems a bit more promising. But I think, looking at you as well, I think TDCS seems to be slightly showing a better profile for schizophrenia and psychosis at this point in time. I don't know if you would agree with that?
Yes.
No.
Thank you.
So for TMS, it's a bit of a mixed bag right now.
Okay, thanks.
Martijn, thank you so much. Everyone, we'll see you here at 2 p.m. for Peter Gaff.